Hello, good evening, everyone.
हेलो अर्चना मैम।
Hi,
गुड
Anjum.
इवनिंग एवरीवन।
Good
हेलो
evening,
मैम।
माला जी. कैसी हैं आप?
मैं ठीक हूँ। नाइस टू सी एवरीवन।
दिल्ली में तो ठंड है, आप तो बिल्कुल ऐसा लग रहा है कि हाय.
थोड़ा ठंड थोड़ा स्टाइल।
स्टाइल तो जरूरी है. आपका तो स्टाइल कोट का मुझे मालूम है. फॉर एवर आई हैव सीन यू ऑलवेज ऑलवेज इन अ कोट. ब्लू कोट, ग्रीन कोट, रेड कोट. वेर एवर आई गो इन एनी टीचिंग आरसीओजी दिल्ली, सब जगह माला जी इज अ स्टेट. उनका वो सिंबल है. यस, माला कोट. नाइस ऑलवेज ना. आशा दी ने ज्वाइन किया था, मैंने देखा
हाँ,
आशा
ज्वाइन
को.
किया था। फिर उन्होंने
हाँ
अपना स्लाइड्स देखा है।
हम्म.
वेंट थ्रू हर स्लाइड्स।
जरूरी है ना.
या
जरूरी है क्योंकि कई मेरा लास्ट टाइम मेरे वेबिनार में हुआ. आई डोंट नो, आई वाज डूइंग एंड आया ही नहीं. पीपल वर सीइंग मी. मैंने कहा मुझे नहीं देखना है, मेरा स्लाइड्स देखना है. So, Sudeep ji, can I also be allowed to share just for a second? I'll check.
Yes, madam, you can share it.
दिख रहा है मैम।
दिख रहा है ना.
यस मैम।
या so like I set up everything. वो सब और फॉरवर्ड भी एक या दो चला देती हूँ. सुदीप जी दिख रहा है
हाँ,
ना.
सब कुछ
यस.
दिख
गुड गुड. थैंक यू सो मच. I'll stop share. I'll stop sharing. Yeah.
so it is one of the burning topics of thin endometrium.
Yeah, I know. I know. Abhi, I was in one of the webinar from Northeast that Kanchan Murarka has done that, and उसमें भी यही था. Like endometrium. They were talking about regenerative medicine plus thin endometrium. I think everybody is looking. ये आशा दी ने start किया है thin endometrium वाला topic.
हम्म।
हेलो
So
आशा
ready
मैम।
to go, ready
हाय
to fly,
हाय
madam.
हाय अंजुम।
मैडम आईआईएम में जा रही हैं भाई. आईआईएम अहमदाबाद.
हाँ, नहीं वो अच्छा है, मेरे को आईआईएम का कॉन्सेप्ट इतना अच्छा लग रहा है ना, एटलीस्ट लर्न समथिंग डिफरेंट ना। तो मैंने ये सोचा है कि मैं ऐसा बोलूंगी कि यानी इट इज मिक्सिंग ऑफ चरक फिलोसॉफी विद चाणक्य फिलोसॉफी एंड द आउटकम इज गोइंग टू बी ओवरवेलमिंग। है ना, यही हो गया ना, हम चरक हैं वो चाणक्य है।
वेरी गुड. वो अच्छा ही है बेसिकली ना. जैसे बायो इंजीनियरिंग ने हमारा कितना चेंज कर दिया है. लाइक
बिल्कुल
एवरीथिंग बायो इंजीनियरिंग इज
बिल्कुल।
really made so much advancement in medicine because you can combine your ergonomics, your laparoscopy, your ultrasound. I think that's phenomenal progress we have done. So we
तो
will
अभी तो
begin
आजकल जितना भी अपडेटेड रहो टेक्नोलॉजी से और इन चीजों से, तो इससे बहुत फर्क पड़ता है।
हाँ, you have to. नो, बिल्कुल.
इसको जरा आप अपन फास्ट करेंगे, मुझे आधे पौन घंटे में निकलना है, मेरा फ्लाइट है अभी
नहीं, आपका आराम से हो
अहमदाबाद का।
जाएगा. हमारा कुछ भी नहीं होता है ज्यादा. वो दिस थिंग जस्ट 7 o'clock as soon
हाँ,
as the clock, because Mala ji is here.
हेलो।
आभा मैम से भी
बात
बात
कर.
हुई थी। शी सेड
आभा.
शी विल जॉइन सून।
हाँ, आभा जी एंड आशा राव.
यस मैम।
एक एक बार जब सबको फोन लगा दो अंजुम. एंड
हाँ
देन
मैम।
वी कैन वेरी क्विक दिस थिंग.
श्योर, वी कैन
एंड
स्टार्ट विद आशा मैम
करा दें.
स्पीक।
आशा
या
जी को मेरे को पता है फ्लाइट कैच करनी है अहमदाबाद की.
ठीक है मैम, मैं कॉल कर रही हूँ।
है ना. व्हाट टाइम डू यू हैव टू लीव आशा दीदी?
मेरा तो ड्राइवर बाहर आके खड़ा हुआ है और मैं 8 बजे निकलूंगी यहाँ से, तो मुझे अभी थोड़ा खाना भी खाना है, तो तुम
खाना खाना बिल्कुल उतना टाइम दे देंगे
दस
आपको.
मिनट 10 मिनट दे देना।
ना
अभी मैंने
बिल्कुल.
सब खाना वाना
सेवन
शुरू कर
सेवन
दिया है।
7:30 विल लीव यू.
हाँ,
या
आजकल बच्चे पीछे पड़ गए कि नो मोर उपवास, नथिंग, सब खाओ पियो, तो अभी मैंने सब खाना पीना शुरू कर
क्या
दिया,
क्या
नो
अभी
टाइम।
चौमासा किधर चल रहा था जो आपने खाना
खत्म,
बंद कर
लेकिन वो भी फिर थोड़े थोड़े बीच में करती थी, वो भी मना कर दिया है कि अब नहीं, अभी आप सब बंद करो, तो मैंने बंद किया हुआ है अभी सब।
दिया? चौदस ना अष्टमी ना पता नहीं क्या क्या करते रहते थे. हमें भी यही लगता था कि कितना व्रत करते हैं भाई. आशा जी, बट यार आई मीन आई थिंक प्रोबेबली टू स्टे फिट यू आर डूइंग इट. ऐसे ही फिट हो.
हाँ,
क्या.
नहीं
दैट्स रियली गुड. मेरे को कई बार लगता है, मैं पता है whenever I go,
माला जी, मुझे सपोर्ट करना है आपको, माला,
बिल्कुल
अंजुम,
बिल्कुल बिल्कुल,
है ना, इसार के
फुल
लिए।
सपोर्ट, यस।
आप लोग मेंबर्स हैं? अंजुम, आप मेंबर हो इसार के? माला, आप मेंबर हो?
यस
आप हो ना? हाँ
इनके डॉटर भी आरसीओजी है, आशा दी।
हाँ हाँ हाँ।
माला की डॉटर
तो
इज ऑल्सो
उसको भी
आरसीओजी।
प्लीज बोलिएगा, है ना?
हाँ
मैंने
हाँ
आज एक वेबिनार था, उसमें भी बोला, दो थे, मेरा
हाँ
नॉर्थ ईस्ट का भी था
हाँ।
और एक मोनिका के साथ भी था, उसमें एक परफेक्शन सीरीज। देर
उसमें
आर,
तो मैं भी गई थी, परफेक्शन में तो अभी होके आई मैं थोड़ा सा लेट ज्वाइन किया मैंने परफेक्शन में।
हाँ नहीं अच्छा
हाँ
था, तो आई टोल्ड देयर ऑल्सो कि भाई आशा
हाँ
दी इज गोइंग फॉर
हाँ।
वाइस प्रेसिडेंट, तो उधर भी बोला।
हाय
वो
वैजंती, यू आर म्यूट। वैजंती, यू आर म्यूट।
Vajanti was introduced to me by you only, and since
हाँ।
then we have connections now. We meet, keep meeting. We probably have
वैजंती, you have to support me for ISAR
Definitely, Dr.
vice
Asha.
president. Yeah, yeah,
I am seeing all your, posters. So all
yeah.
the very best, and I'm sure
Thank
you
you,
will,
thank you,
you will.
thank
And right
Ma'am,
now, secretary and
Ashara ma'am is joining in a minute.
yes. And hello, Dr. Archana. Sorry, I was on mute, and so I thought I'll say hello. Hello, Dr. Anjum. And
Hello
thank
ma'am,
you so much
welcome.
for giving me this opportunity to be part of, today's webinar. Thank you. Hello, Dr. Mala. I don't
नाइस
think
टू
we
सी
have
यू
met.
डॉक्टर वैजयंती।
Yes, yes. Thank you. We have met briefly, maybe in one or two meetings. Yes.
यस यस यस
you।
यस।
शिल्पी से तो मैं अभी वहां मिल ली थी ना,
Hello.
IHS में मिल ली थी।
Yes,
हाँ
yes, ma'am. That was nice meeting you.
हाँ। शिल्पी,
Shilpi,
मेरे
All
लिए
the
थोड़ा
best.
करना है काम आपको उधर।
Yes, 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 ma'am. Yes, ma'am. I'll spread
Shilpi,
the
and we
message.
share
Yes.
embryologist. Na?
Yeah, yeah. Archana, ma'am. Yeah, thank you for this invitation. And it is a good platform to meet everyone
I
here.
know.
या
Yes.
So I think it's clock
वी
is ticking
स्टार्ट या।
7. That Dr. Asha is joining, and Dr. Abha was to join, Dr. Abha Rani. So maybe I'll just call her. By the time you can
Abha
start.
Rani is there, I can see her.
या डॉक्टर आभा इज हियर।
Yeah.
Yeah ma'am.
Yeah, so let's start.
Yes
Then
ma'am.
invite people. So Deepji,
Yes.
you can give countdown.
Yeah, just we'll start with the lamp.
Yes.
हेलो, मैं मीटिंग में हूँ, आप एसएमएस कर सकते हो या व्हाट्सएप कर देते हो। ओके।
Hello everyone. I welcome you all the respected dignitaries and the participants. This series focus under RCOG West Zone is, as you know, brainchild of Dr. Archana Baser ma'am, and she has personally chosen topics which are relevant for her clinical practice. So the topic for today is thin endometrium. As we know, endometrial resection is very important for the success of any pregnancy. So we have stalwarts from the field of reproductive medicine to share their knowledge with us, and also an interesting panel with fertility experts from all over the zone. So I now request Archana Basir ma'am, who is the program director, to welcome the chief guest and guest of honor. Ma'am, over to you.
Thank you, Anjum,
Yeah,
for
ma'am.
your opening the webinar. At the outset, let me thank all the dignitaries on the dais and the speakers for today. And this basically focus series, we have been able to do it because Dr. Purnima Satoskar, our chairperson of the Waste Zone RCOG, has given us this platform that yes, you can do it, and focus mainly on the very interesting topics of the infertility. And I'm being flanked by two very strong, powerful core people in this webinar focus is Dr. Anjum Sayed and Dr. Rupali Dharwadkar. Rupali today is not here because she's not well. So I think this time Anjum has done everything, coordination. So thank you, Anjum, for all
Thank
this.
you for the opportunity, ma'am.
And today we have combination of north, south, east, and west. So from the north we have Dr. Abha Rani, from south we have Dr. Asha Rao, and from the north we have Dr. Mala Srivastav, and from the west zone and central zone we are here as a speaker and moderators in this webinar. So at the outset, let me just give me the CV of our guest of honors, Dr. Anjum or Sudeep ji.
Yes, ma'am.
So, so
Dr.
first, I
Abha,
think,
ma'am.
I think, yeah,
Yes.
Dr. Abha Rani Sinha, she is a great friend and she is Vice President Foxy 2026, been ICOG Governing Council member, and she is Principal SKMC Muzaffarpur. And what I found about Abha Rani ji is she is very down to earth person and very, very helpful and very friendly person. She's organizing a very big conference in Gaya, for which she has been really inviting us personally. So Abha Rani ji, I would like your words of wisdom and advice for this webinar. Over to you, Dr. Abha.
And I would also like to thank Anjum for constantly reminding me about the webinar.
आवाज
Thank you.
नहीं आ रही मैडम
Doing it so well.
मैडम आवाज नहीं आ रही
अच्छी बात है हमारे में तो full. Am I audible now, Archana?
Slightly better, ma'am.
Okay.
But still,
But my volume is full. I don't know why. Okay, now?
yes, better now.
Okay, actually, I've got a cold, so perhaps I'm getting choked also. So, okay, so thank you, Dr. Archana and Dr. Anjum, for
Thank you.
inviting me as chief guest for today's very, very focused webinar, that is AICC RCOG West Zone webinar. And the topic that has been chosen is very relevant. We all know that thin endometrium, it definitely has an effect.
Ma'am got disconnected, I think. Abha, ma'am?
Abha मैम आवाज नहीं आ रहा है, थोड़ा सा पास में आना पड़ेगा आपको.
शायद डिस्कनेक्ट हुआ है, मैम.
So maybe let's just wait for Madam to join again. Meanwhile, we can have Dr.
Yeah.
Mala or Dr.
Yes. Dr. Mala, ma'ams. Yeah.
Yes. So I have known Dr. Mala Srivastav for a long time, and she is a gynec endoscopic and robotic surgeon at Sir Gangaram Hospital. Sorry, Abha ma'am is here. Can we just have Abha ma'am back?
Abha, ma'am? We are not able to hear you. Ma'am was saying she has a bad throat as well.
Okay, so let's move on to Malaji and Madam ka kuch karo. Yeah. So she's been President Narchi Delhi chapter, Vice President ISOPA, past President Association of Gynecologists of Delhi, and I've seen her in the conferences, met her, very nice person and a very good human being. Just one phone call and she will come to your, okay, ma'am, just come. She's there for us. So lots of awards, and she's been member of different bodies, and she's a great teacher as well. So I would like Dr. Mala to give her advice and words of wisdom for our webinar on thin endometrium, and then we'll connect with Abhaji again.
Good evening, everyone. I must congratulate Dr. Archana Madam as well as Dr. Anju and for having such a nice webinar on such a pertinent topic. Thin endometrium, new solutions, grow the bed, improve the success. And the topics definitely, Dr. Asha Bakshi is going to do a great job to the thin endometrium and edema. And of course, Dr. Archana is going to speak about PRP in thin endometrium, what the evidence says. And we are looking forward for the great panel discussion by none other than Dr. Mrinmay Dharmadhikari. And we have lots of young, enthusiastic panelists in those panel discussion. And I'm sure today's evening will be a great learning experience for all of us. And we are looking forward for a great webinar this evening. Over to you, Dr. Archana, as well as Dr. Asha. And we are looking forward for the great scientific session, which is going to happen just now.
Thank you very much, Malaji. Your commitment to webinar and your commitment to teaching and encouragement to stay updated is great and appreciated. So now, do we have Dr. Asha Rao here? Asha
Yes,
is
I've joined.
Yes,
Yes,
madam
yes,
has joined.
Archana.
Hi. So now let me
Yeah.
introduce Dr. Asha Rao. Asha Rao and Asha Bakshi share the birthday, they share the name, and they are great friends, and both of them are good endoscopic surgeon. So it's really my proud privilege to introduce Dr. Asha Rao. She is director of Rao Hospital and Care, Coimbatore, and she has affiliation uh, like to ICOG, past president Coimbatore, and she has conducted UA Foxy South Zone, and now she has lots of publication, and she's known as a endometriosis women. She has done so much great work in endometriosis as an endometriosis chairperson, and she's running a very wonderful unit along with her son. And I would like her advice and inputs on this webinar, Thin Endometrium. So over to you, Dr. Asha.
Thank you, Dr. Archana. Very glad to be here with all the galaxy and all my dear friends. And it's a very nice, very important topic that you have chosen on thin endometrium. And more than anything, you are so dear to my heart. And Archana is such an excellent clinician, sonologist, and very, very good in whatever she does. And she has had a fantastic tenure as a vice president, and now she's heading for a bigger post. We are very happy about it. And she's such a vibrant personality. I have enjoyed your hospitality at Indore. In spite of those difficult days post COVID, it was such a fantastic conference, and we will always cherish the memories of this conference. And I would definitely love to see you going ahead, climbing higher steps, and wishing you all the best, Archana, in your future endeavors.
Thank you,
Thank
Asha.
you.
Ma'am, I think Abha ma'am is back.
Yeah, Abhaji, please come over. Yeah.
Okay, am I audible now?
Yes, madam, 100%.
Okay. Thank you so much, Dr. Archana, for inviting me as chief guest for today's focused webinar of AICC RCOG West Zone. And Dr. Anjum also has been very kind organizing it and also coordinating with us. So what to speak of Dr. Archana? She, as Dr. Asha has rightly said, she's a great sonologist, a great clinician. Dr. Archana, I want to say. And Dr. Asha, of course, she is also a great clinician. And Dr. Archana is going for the elections this time, and my best wishes to her. I know she'll do a very great job. So thank you once again for inviting me. And for today's webinar on thin endometrium, I know it's a very relevant subject, especially for the people who are doing infertility practice, because thin endometrium, it definitely affects the reproductive outcome. And uh, today, I think we'll learn what are the factors which cause thin endometrium and how can we tackle it. So we have two great speakers, Dr. Archana and Dr. Asha. And of course, we have a panel discussion after that. So best wishes for the whole webinar and good learning experience for all of us. Thank you so much once again for inviting me as the chief guest.
Thank you, Abhaji. Thank you so much for coming, sparing your time. In spite of bad throat, you could really join in, and really very, very thankful to you, and very kind of you to for your encouraging words. So thank you, and please stay with us. And now over to Dr. Anjum to introduce Dr. Asha Bakshi, and the chairperson to
Yes,
invite
ma'am.
Dr. Asha Bakshi.
Yeah, thank you, Archana ma'am. Thank you, Abha ma'am, Mala ma'am, Asha ma'am, for the words of encouragement. We'll be soon starting the talks from two stalwarts in fertility, Dr. Asha Bakshi ma'am and Archana Basir ma'am. For that, I would like to invite our chairpersons for the session today. Vaijanti ma'am.
Hello.
Vaijanti ma'am, I welcome you as the chairperson. Madam has been a head of department and consultant fertility specialist, KIMS Fertility. She has also been the director and consultant fertility specialist of the Mother to Fertility, Hyderabad. She has number of things to her credentials, including clinical fellowship in reproductive medicine and MSc embryology from UK. She has done subspecialty accreditation in reproductive medicine, RCOG. She is also managing community member of PCO Society and Fertility Preservation Society. I welcome you, ma'am, as the chairperson for today's session.
Thank you, Dr. Anjum, for that kind introduction.
Can I now introduce our second chairperson, Shilpi Sood, ma'am? Shilpi Sood, ma'am, I welcome you.
Thank you, Anju.
Madam has been the consultant managing director of Safal Hospital and Diva Fertility Center, also past secretary of Indian Fertility Society, Vidarbha chapter. She has been past vice president of Nagpur Obs and Gynae Society. Currently, she is running a dedicated Safal Hospital for high-risk pregnancy and advanced fertility center. She has number of achievements to her credit, and among them is organizing chairperson of FertiQuest 2019 and also contributed chapters in books and publications in national and international journal. Ma'am, I welcome you again.
Yeah, thank you.
Can I request Vaijanti ma'am to invite our first speaker, Dr. Asha Bakshi ma'am.
Thank you. Good evening, everyone. And Dr. Asha Bakshi ma'am indeed needs no introduction. Everyone knows her. But it is my privilege and honor to introduce her. She's currently serves as the secretary of ISAR, and she is a FOXY representative, member of the ultrasound committee of AOFOG, and she's the founder chairperson of MP, IAGE, and MP ISAR. Her previous leadership roles include chairperson of the FOXY Infertility Committee, member of the ICOG Governing Council, past president of IOGS, vice president of FOXY West Zone. So these positions reflect her sustained commitment to academic excellence and organizational leadership. She has been recipient of several prestigious honors, including Dr. Kumud Tamaskar Award, Padma Shri Dr. S.K. Mukherjee Award, and multiple excellence awards from Patrika, Times of India, and Nagar Nigam Indore. She's also credited with achieving the first ICSI, TISA ICSI, and Micro TC ICSI babies of MP, a landmark contribution to ART in Madhya Pradesh. She has also served as organizing chairperson for numerous national conferences and contributing significantly to advancement in reproductive medicine. So she was very kind to invite me for the recent national embryology workshop, for which I was there in Indore recently. So please join me in warmly welcoming her. And over to you, Dr. Asha Bakshi. And I also would like to take this opportunity to wish her all the very best with the upcoming elections as second VP of ISAR. All the very best. And today she's here to enlighten us on thin endometrium and enigma. Over to you, Dr. Asha. Thank you.
Thank you very much, Vaijanti, for the kind introduction. And I would like to thank Dr. Shilpi also for chairing the session. And lots of thanks to Anjum, who has been coordinating everything. And I'm really, I shouldn't thank because friends don't need thank. And that is Dr. Archana Basir, who is very close. And we have been since years together since I came back from England. She followed me. After, I think, 4 or 5 years, she came. And since then, we are working together and a very close relationship. And I know her as a very dedicated person, a good leader, very well organized and very knowledgeable, and very good clinicians. And she's open to suggestions. So any problem is there, we discuss amongst ourselves and we solve lots of problems. So that's Archana. And I wish her all the best for the upcoming, candidature. And I'm sure, Archana, you are going to do well.
Thank you, Ashwati. Thank you for kind words and
Yeah.
same best wishes for you as well.
Thank you so much. So I'll share my screen now, and I'm going to talk on thin endometrium today. And thin endometrium, we all know, is a pain for all of the ART specialists, not only ART, I think for everyone. So I think you can see my screen now.
Yes.
So, Merry, just Christmas has gone yesterday, and today is the Boxing Day. And especially if you are on the platform of RCOG, you can't forget. Christmas really makes you remember those good old days when always you used to be on duty because you are not being Indian. I will be always duty on Christmas Eve or on Boxing Day. But I enjoyed Christmas there, so I thought I'll wish you all the Merry Christmas. And now coming to the thin endometrium, I'll just, yeah. So, so coming to thin endometrium, we all know that this is a bad news for all of us, whether we are IVF specialists or whether we are general infertility specialists. So, and we all know that embryo is ready, beautiful embryo is there, and when the endometrium is not good, then it's a disaster. And it has been known that only 30% of embryos transferred into the uterine cavity after ART successfully implant despite being of good quality. And inadequate endometrium poses a substantial threat to the endometrial receptivity. Thin endometrium is defined as mild luteal, usually in the mid luteal phase when endometrial thickness is less than 7 millimeter, and it can affect the endometrial tolerance. And it can affect the endometrial tolerance, leading to poor implantation rates and clinical pregnancy. And prevalence increases with the age. So when it reaches almost 25% in natural cycle in women over 40 years, and in infertility patients, it is 2 to 3%. And especially when you are doing assisted reproduction, 2/3 of the failures are due to endometrium intolerance and remaining 1/3 due to embryo quality. This is characterized by poor glandular epithelial growth, high impedance to blood flow, decreased VEGF expression, and poor vascularization. And it has been found that endometrium less than 7 millimeter negatively impacts the live birth rate, clinical pregnancy rate, and implantation rate. So ideal endometrium is between 7 to 14 millimeter. And when you see this type of endometrium, the triple line in mid-sagittal plane, the endometrium is triple line, nearly 8 to 15 millimeter, and vascularization of almost zone 3, then you are really very happy that at least one hurdle you have crossed. And when we see the endometrium, it's not, we have to check for the morphology also. So sometimes it may be hyperechoic endometrium, and that's not a good news because the implantation is only 17.6%. In isoechoic endometrium, the implantation is 33.3, whereas it is the best with triple line endometrium. And it's not only the endometrial morphology, but at the same time, we have to check the endometrial volume also. And it has been suggested that the minimum endometrial volume associated with pregnancies more than 2 milliliters. So most of the pregnancies, they occur when the volume is between 2 to 13 milliliter. Particularly, it is very important when there are synechiae, adenomyosis, and uterine anomalies. So, and these days, with the help of 3D ultrasound, we can very well assess the endometrial volume. Histoscopy is another a very good tool in assessing the thin endometrium, and we can see endometrial atrophy, adhesions, scarring, and vascular deficiency. So that also helps us in the reconfirming the diagnosis. And hysteroscopy at the same time offers us an opportunity to do certain procedures like lateral metroplasty, or in Asherman syndrome, if it is there, then we can do release the endometrium, because Asherman's is really associated with thin endometrium. And if the adhesions are thin, flimsy, then results are very satisfactory and you do get good results. But especially if the endometrium is thick and the adhesions, endometrial adhesions are thick, and sometimes they are calcified, then the results are not that good. The whole cavity may be contracted, but still it is worth trying to do lateral metroplasty, adhesiolysis. At the same time, you can put in a small balloon after the pediatric balloon, or there are special device available after the adhesiolysis, and then this can be followed by PRP, and maybe that will help in restoration of the endometrial cavity. So it's always worth trying, though thick adhesions are really bad news along with the thin endometrium. And I'm not going to talk much on endometrial PRP because Dr. Archana is going to talk about endometrial PRP. But during hysteroscopy, again, it gives an opportunity. If you want to do subendometrial instillation, then you can do it during the procedure. Now, if you do histopathology of such endometrium, then you'll find that there is decreased glandular density, abnormal glandular structure, nuclear compression, sparse blood vessels without smooth muscles. And if you do immunohistochemistry, then that reveals pronounced stromal fibrosis phenotype in thin endometrium. And causes, we all know one which we have been taught since ages, and that is iatrogenic factors, and especially rigorous curettage affects the endometrial thickness. Then there may be many intrauterine surgeries, hysteroscopic procedures, hysteroscopic myomectomy. All these can affect the endometrial thickness. Pelvic irradiation, use of clomiphene citrate, all these are associated with thin endometrium. Infectious causes, initially we just used to think about postpartum endometritis, septic, abortion, especially these days medical termination of pregnancies occurring, and many a times there are these small RPOCs, and they may be leading to intrauterine adhesions, chronic endometritis. And as such, even without any history, there may be chronic endometritis. Long time ago, we used to think that endometrium is always sterile, but now the RNA PCR with the technique is now available to us. And it is being found that even in endometrium, you can find lots of organisms, and it's worth identifying them, especially if there is recurrent implantation failure or persistent thin endometrium, and then treat that with appropriate antibiotic. Then structural congenital anomalies, we have already discussed about Asherman syndrome. Mullerian anomalies, especially if this is a unicornuate uterus, septate uterus, then these situations are also associated with thin endometrium. Then endocrine and hormonal disorders, very important to check for these, and if they are there, at least they are correctable. So it's not a bad news. Then sometimes fibroids, adenomyosis, they can also alter the uterine cavity, and at the same time, assessment may be difficult. So very important, especially if adenomyosis, then that transformation zone is so thick that sometimes it is very difficult to assess whether it is thin endometrium or not. And whenever you do frozen embryo transfer, then in that also many a times the patient does not respond to your preparations, and there may be thin endometrium, and maybe there is sometimes gene mutation of estrogen receptors. So what are the management strategies? So most important, especially if you are doing an embryo transfer, then think about estrogen supplementation. So the forms can be oral, transdermal, gel, spray, vaginal tablets. And very important to check the duration, and in that you can modify and tailor according to the individual need. And even using the modified natural cycle, and in that if required you can add a little bit of estrogen, or you can even add FSH, and that also sometimes improves the endometrium. And letrozole induced endometrial cycle, then that also can help in sometimes with estrogen the patient is not responding and she responds with letrozole. So you have to really use your own experience and try whatever way you can to improve the endometrial thickness. And estrogen supplementation, we know all various preparations are there. Even in India nowadays, gel is easily available, though they are saying that transvaginal estrogens, they improve the estradiol most. And many times we have used estradiol preparations vaginally also to improve the endometrial thickness. So it's worth trying, though commercially these preparations are not available. Now, what is the dose? So for oral estradiol, our routine dose is 4 to 8 milligram. And for transdermal estradiol, it is patches delivering 0.1 milligram per day or gels with 1.5 to 3 milligram per day. Transdermal routes may be preferred in women with clotting risks. But sometimes we have to use high dose estrogen protocols, especially in resistant cases. The dose may be escalated up to 12 milligram per day orally or 6 milligram per day transdermally. And sometimes we may have to combine both as well. So equal improvement and coming to recently, till now we had been using estradiol valerate, but now estradiol hemihydrate has been introduced. So is there any difference? And the studies have shown that there is equal improvement in endometrial thickness with estradiol hemihydrate as well as estradiol valerate. So you can use any. And there are many studies that have shown that there is improved pregnancy outcome with letrozole plus estrogen in frozen embryo transfer for thin endometrium. And this increases endometrial thickness, improves pregnancy rates in women with thin, unresponsive endometrium compared to estrogen alone. And mild stimulation protocol may be considered upfront for better FET outcome. So here again, you have to use your own knowledge of physiology, pharmacology, previous experience, and then you can track. So basically, the thin endometrium, which is unresponsive to increasing doses of estrogen, is described as unresponsive or refractory endometrium. And this is most situation, and this is what we all were afraid of. So coming to, so in these situations, sometimes there may be chronic endometritis, and chronic endometritis can be suspected on hysteroscopy because you can find atrophic endometrium, micropolypi, some necrotic area. So you can identify chronic endometritis through hysteroscopy. And it is basically persistent inflammation of the endometrium. It is often asymptomatic, but may lead to infertility, recurrent implantation failure, and recurrent pregnancy loss. Impaired deciduralization, local immune abnormalities, and excess immunoglobulins in the endometrium result in implantation failure. And the causative agents may be E. coli, streptococci, enterococcus, staphylococcus, and in certain areas, especially in India, Mycobacterium tuberculosis. So treatment with a specific agent can improve the implantation rates and decrease the rate of abortion. But well-designed prospective studies are needed. But lot of interest has been revived these days about chronic endometritis, and even in our center, usually if there is recurrent implantation failure, we do, or if there is thin endometrium, then we do check for chronic endometritis. Now, other adjuvant therapies like low dose aspirin, vitamin E and L-arginine, and sildenafil citrate. So low dose aspirin, it improves the blood flow, and evidence is mixed. Some studies show benefit, some do not. Similarly, vitamin E and L-arginine, they are also antioxidants with vasodilatory effects, and the use may enhance endometrial perfusion. Sildenafil citrate or Viagra, which is the commercial name, it can be used vaginally or orally, and it increases again the uterine blood flow. Some studies show improved thickness and pregnancy rates. Now coming to the rejuvenation therapies. So Dr. Archana is going to talk about PRP, so I'll leave that. But stem cell therapy, the source is bone marrow derived or menstrual blood derived stem cells, and the indication is severe Asherman syndrome or unresponsive thin endometrium. But still it is experimental and requires further validation. GCSF, again, it can be given in intrauterine or subcutaneous, and indication is refractory thin endometrium, and evidence is limited but promising in improving thickness and implantation. So coming to GCSF, it is produced by, it is a cytokine that is produced by stromal cells, macrophages, decidual cells, and other immune organs, and it stimulates cell proliferation, differentiation, and helps in improving embryo transfer. The dose is 60 to 300 milligram on the day of HCG trigger or embryo transfer. It can be given subcutaneous or intrauterine administration. And the meta-analysis shows increase in clinical pregnancy rates and endometrial thickness with GCSF administration in both fresh and frozen embryo transfer. But larger studies are required to validate the use. So still it is a controversy. Then coming to HCG. HCG is we all know is secreted by embryo even before implantation, and it is important regulatory factor for embryo endometrial communication. The dose that is used is 500 to 1000 units, and it is instilled in uterine cavity before embryo transfer, and it can bind to receptors to upregulate the expression of factors including VEGF, LIF, and MMP9. These cytokines improve maternal fetal immune tolerance, upregulate endometrial thickness, and improve outcomes. And miscarriage rate was significantly lower with intrauterine HCG administration as compared to controls. But this was not reported in other reviews. So still, whether it is very useful or not, that needs to be further validated. And it has been suggested that it increases invasive potential of trophoblast, and usually it is administered just before embryo transfer or even 72 hours before embryo transfer, and those I've already described, and that is 500 to 1000 intrauterine. Fusion and tolerance. Improved response with low dose aspirin and HRT on patients who had undergone hysteroscopic adhesiosis. In a prospective randomized study of aspirin in patients with thin endometrium, aspirin improved pregnancy rates but did not improve the thickness. Sildenafil citrate, it enhances the vasodilatory effect of nitric oxide on vascular smooth muscles. Endometrial thinning may be caused by impedance to high blood flow in uterine arteries. Vaginal administration may increase endometrial thickness and clinical pregnancy rate. In a randomized placebo-controlled trial of 66 patients with thin endometrium, receiving sildenafil showed twofold improvement in pregnancy rate. Now, vitamin E and pentoxifylline. Vitamin E hydrolyzes to produce tocopherol, which increases the estrogen levels and is also an antioxidant. Pentoxifylline is methylxanthine derivative and is an antioxidant as well as vasodilator. In a retrospective study of 143 patients, the combination therapy of vitamin E and pentoxifylline for more than 2 months significantly improved endometrial volume and endometrial thickness. Now coming to platelet-rich plasma, I think I'll leave this topic. Then we come to autologous blood derivative PRP. That also I will leave. So this again, I believe. Stem cell therapy is an emerging approach for treating thin endometrium involving stem cells to regenerate and improve the endometrium. Mesenchymal stem cells, particularly those derived from bone marrow, adipose tissue, and menstrual blood, have shown potential in regenerating the endometrium and improving the thickness. They can be administered as intrauterine infusion or subendometrial injection. It is hypothesized that endometrial stem cells have a crucial role in this uterine homeostasis and that thin endometrium is the consequence of loss of endometrial stem cells. It should be used in institutes with multidisciplinary approach. Not many RCTs or comparative studies are available regarding the efficacy of stem cells on endometrial rejuvenation. So this is again clinical efficacy and safety of stem cell based therapy in treating Asherman syndrome. So this is a systemic review and meta-analysis. So in this 427 studies were identified, 8 of which were eligible and included. Stem cell combined hormone therapy achieved a higher likelihood of improving the menstruation and enhancement of pregnancy outcome and a mean increase in 3-month endometrial thickness. And a subgroup analysis indicated that 6 and 9-month endometrial thickness increased significantly with stem cell based treatment. So moreover, no obvious and severe adverse reactions were observed during the process of stem cell therapy. So I think more need to be done, but evidence is coming in its favor. And this is another study which says that unresponsive thin endometrium caused by Asherman syndrome treated with umbilical cord mesenchymal stem cells on collagen scaffolds. So there were collagen scaffolds on which the stem cells were there. And it has been found that unresponsive thin endometrium caused by Asherman syndrome is the major cause of uterine infertility. And the study is to evaluate the effect of transplantation with collagen scaffold and umbilical cord mesenchymal stem cells, because that will keep it there for some time. It has been found that this combination therapy is promising and potential approach for treating women with unresponsive thin endometrium caused by Asherman syndrome. Now, another thing that can be added is hyaluronic acid hydrogel integrated with mesenchymal stem cells, secretome, to treat endometrial injury in a rat model of Asherman syndrome. So these are all futuristic things. So stem cell therapies have made strides towards treatment of Asherman syndrome. Despite the progress, they are limited by risk of tumor formation, low engraftment rates, as well as storage and transportation logistics. A growing body of evidence supports the theory that delivering media conditioning with mesenchymal stem cells might be a promising alternative to live cell therapy. A new strategy for loading cross-linked hyaluronic gel with mesenchymal cell secretome is reported. So these are all futuristic things which may come. Then Botox is being used everywhere. So let's see whether it is helpful in thin endometrium or not. So it has been said that it enhances angiogenesis and endometrial receptivity by modulating IGFBP3 and osteoprotein signaling pathways. It reduces inflammation and promotes vascular remodeling. The preclinical evidence in murine models, Botox improved endometrial thickness and receptivity. However, human trials are limited. So option where nothing helps. You can go for surrogacy, you can go for adoption, or even expectant management, because time is the best healer. So let's talk about expectant management. Sometimes the conservative approach is the most appropriate, allowing the endometrium to heal naturally. The endometrial lining has a high regenerative potential, especially after resolving underlying issues like infections and inflammation. Cases of mild chronic endometritis, post-surgical recovery, these patients may be left for some time and you'll find that the endometrium gets better. Lifestyle, this can, at the same time, you can advise them lifestyle and nutrients and exercise, manage stress, nutrient-rich diet, herbal supplements, limiting caffeine, alcohol, smoking, acupuncture. All these things may help, as in any other case. And when there is thin endometrium, there are chances of obstetric complications. So even if you're a patient with thin endometrium, if she conceives, then you have to be aware of high miscarriage rate, high chances of ectopic pregnancy, preterm birth, and low birth weight. So very, very important that don't just get excited that the patient has conceived. You have to really be very careful even for the obstetric management. So overall, my conclusion is modulating the microenvironment, targeting cellular senescence by anti-aging pathways, and adjusting immune response to create a receptive and supportive environment is essential for successful implantation. Most of the times, it is difficult to find the cause, but identification and treatment of intrauterine adhesions, chronic endometritis, lateral metroplasty, increasing the dose and changing the route of administration of estrogen may help. Intrauterine HCG, PRP, stem cells, and Botox are still experimental. Patients conceived with thin endometrium should be closely monitored for miscarriage, ectopic pregnancy, and other obstetric complications. So at the end, I would like to thank you all for the patient listening, and I would request you all to consider my candidature for second Vice President ISAR 2026 to 28. And I since 212, I am in managing committee continuously. I have been ISAR, serving ISAR, and I would always be there to serve ISAR. So thank you very much. And thanks, Archana, for giving this opportunity.
Thank you, Ashadi. I mean, I'm sure chairpersons will have lots of comments to make, but before I hand over to chairpersons, it was excellent. Nobody, like, you're an stalwart, and the topic you have covered, each and everything you have covered about thin endometrium, I'm sure so many things, like it was an enlightening talk. I think Vajanti would agree with me. So, uh,
Thank you, Dr. Asha. Excellent presentation. You have extensively
Thank
covered
you.
all aspects, both related to the causes of thin endometrium, organic pathology, how to, how to identify it, how to treat it, and then move on to the other hormonal aspects. Thank you very much. The one thing which I want to ask you, if there are any questions in the chat box, are we taking it, Dr. Anjum, or can I go ahead?
Ma'am, I don't see any questions as of now, but if there are
I'll
any
just
questions,
ask
we can take it.
one question for ma'am, and then we'll move on. Thank you, Dr. Asha, once again. At what when we talk about refractory endometrium, what is the thickness you would consider as not to go ahead? You have tried all measures, but still it is refractory. So, what is your sort of limit below which you would not go ahead with an ET? Do we have evidence on that?
See, the literature has said that even a 6 millimeter endometrium, if the pattern is good and the morphology is good, you can go. Even I have patients with severe hypogonadotropic hypogonadism. And these patients, whatever you do, the endometrium doesn't come that well. But if it is a triple line endometrium and the flow is good, then I would go for it, even if it is 6 to 7 millimeter. But if it is, say, maybe it is 8 millimeter, but it is hyperechoic, then I wouldn't go for transfer. So lots of things you have to take in your consideration. But below 6 millimeter, if it is not that good, vascularity is not good, I would not go for transfer.
Okay. So recently there was a publication in Fertility and Sterility looking into more than, I think, 30,000 ETs, 30,000. And they have shown that even if it is less, there are pregnancies, albeit less compared to what we saw. So as low as 5 also, they have been able to show some pregnancy. So I thought I'll share that with you.
Yeah. I
Brilliant
read that
presentation.
article.
Yes, yeah, brilliant. Thank you. Thank you very much.
Just a word here, Dr. Asha Rao. Asha, this was an excellent talk that you have delivered. And in my experience also, I feel 4 millimeter, 5 millimeter also have conceived. Once we had a patient with 1 ml uterine volume. In the first couple of cycles we tried for her, she was not improving. Then metroplasty, GCS, everything was done. And the lady said, you transfer it now or never, because the husband is going away somewhere. So she'll be transferred. And we had to transfer at 1 ml, but vascularity was good compared to the previous cycles, and she conceived. So I think this is the thinness that I have seen.
Yes.
Yeah.
Yes.
And I wish you all the best, Asha, in your
Thank you.
All the
Thank you.
best. All the best, Asha.
Thank you, Shilpi. Thank you, Asha. Thank you, everyone. Thank you.
You are leaving.
bye,
After me,
bye,
then I have
Ashadi. You can leave, and your driver is
travel.
waiting.
Yeah.
So thank you very much for a really nice lecture and really covering the topic so well.
Thank you.
Thank you, Asha. Best of wishes from all of us for your candidature, and thank you for a wonderful
Thank you, Anjan. Thank you.
schedule. Thank you, ma'am.
Bye.
May I now request our chairperson, Shilpi Sood ma'am, to introduce our esteemed speaker, Dr. Archana Base ma'am.
Yeah. Thank you, Anjum. Dr. Archana is a vibrant personality, we know, and she's a director at Akash Hospital, Indore. And she has held many positions in the past, like chairperson, Foxy Imaging Science Committee, organizing secretary for ISAR, managing committee member, an IAG, an imaging science member, an imaging science committee chair, and CEFOG 2020. Presently, she is holding a chairperson, MP ISAR, and she's a fellow representative AICC RCOG, joint secretary ISPAT, and she is a organizing secretary of. She was organizing secretary of AICOG 2021 Indore, and that was the successful conference I could see. And presently, Dr. Archana is contesting for the Foxy Presidential Candidate Election 2026. I know Dr. Archana very well, and today she will be talking about the one of the very crucial the topic, like PRP for the thin endometrium, and we know this is one of the regenerative approaches, and it has a lot of interest because of their potential to enhance the endometrial growth, improving the vascularity, and modulate the local immune response and inflammatory pathways. While we know a lot of evidences are there, and Dr. Archana will be talking about the evidences. And I welcome Dr. Archana, and we are very much waiting for your lecture. Thank you.
Hi everyone. Thank you very much for kind introduction. And like whenever you are, so I just ran out of battery, so I rushed to get my this thing. So it's a hard act to follow after Asha Bakshi's a good lecture on things. So let me allow to share my screen. Can you see my screen?
Yes.
Yes, we need a full screen.
Yeah, I'm just doing it. Yeah.
Yes.
Just switching the place. Thank you for yeah. So, what I'll be thank you very much for kind introduction, and I shall be talking to you on PRP role in thin endometrium. I think Dr. Bakshi has covered in great detail about the endometrium. I'm just going to talk a very little, and this is something which is doable because PRP is something all of us who are doing hysteroscopy. It is very easy to do, and there are evidences which says that yes, PRP has been helpful in increasing the endometrial thickness, and it is helpful in IVF to get a successful outcome. It is, as I said, it is a viable and intact concentration of human platelets in a small volume of plasma. So it contains 3 to 5 times higher concentration of platelets than whole blood. It is extremely rich in plasma proteins, growth factors, and cytokines. So we have been talking about the growth factors, cytokines by giving different ways, but this is a directly injecting it into the endometrium. So how do you really do a PRP preparation? It is again a process. Once you can learn the process, or you can teach one of your staff, or whosoever is managing your IVF lab. It just collect the blood sample, and you have to put the blood sample in the centrifuge machine, and that centrifuge, it's written like 1500, or then again for 2000. So that is how you have to do. Place in a centrifuge, spin it, separate the platelet from rest of the blood component, extract the platelet rich plasma. About 3 to 6 ml of platelet rich plasma is extracted, and that PRP is injected into the endometrium. So now, what is the role in infertility? It helps in implantation, and it helps in improving the thin endometrium. How does it help in implantation? PRP increases expression of adhesion molecules on endometrial surface. Thus, it increases the chances of implantation. So this is all the different endocrine mechanism, paracrine endocrine mechanism by which the PRP helps in the implantation. So it is intrauterine infusion of autologous PRP in women undergoing IVF. There was a meta-analysis done in Ghana where they did 625 women. What they found that the clinical pregnancy rate was good, and endometrial thickness increased after doing the PRP. This is the article which is published in February 2020. Now, what is the effect of PRP on pregnancy in women with recurrent implantation failure? Because we are not only using PRP for during IVF in women with recurrent implantation failure, or in some people are using it in women where there has been a history of recurrent early miscarriages also. So it is a study again done in May 2020 on 98 women. Clinical pregnancy p-value was 0.001, ongoing pregnancy again 0.001, and implantation rate was 0.001. So effect of autologous PRP in recurrent implantation failure, again a randomized control trial is here, which was done in September 2020. They studied 97 women, And what they found that chemical pregnancy rate was higher in the PRP group than in the control group. And clinical pregnancy rate was higher in the PRP group than in the control group by another study as well. So what is the role in IVF? Again, in implantation, thin endometrium, you can do it in premature ovarian insufficiency and even in male infertility. PRP has a role. So we have cases where we have done the double PRP, like done the PRP in the ovaries as well as PRP in the endometrium as well. So in how do you define thin endometrium? Already we had a talk with Dr. Bakshi. It is defined as endometrium less than 3 millimeter on day of HCG. What does PRP do? It supplies supraphysiological amounts of essential growth factors to provide regenerative stimulus for promoting tissue repair. Mostly, whatever trials are there, they are uncontrolled small trials. For example, somebody has done a trial of only 10 women, which was published in 217, and endometrial thickness increased more than 7 millimeter after 2 injections of PRP. Endometrial ET was carried out for all of them, and 5 patients were pregnant, that is 50%, and 4 of them continued their pregnancy normally. So these are modest journals. Can autologous platelet-rich plasma expand endometrial thickness? These are the different articles which are there on the. You can go through them whenever you want to practice, like doing the PRP. All positive. All the reports showed highly significant improvement in endometrial thickness. All were in frozen embryo transfer cycles. All were done 48 hours before embryo transfer, and all reported high pregnancy rate. So we should be very cautious also about this. So thin endometrium, intrauterine infusion of PRP has been conducted by women with thin endometrium on cycle day 12 to 14. Over 2019 to 2022, 20, almost 27 women were injected with PRP, and this was followed by adjuvants as estradiol supplementation and gonadotropin injections. So outcome was, again, significant improvement was achieved in 16 cases and FET was done. Pregnancy was achieved in only 2 cases, 11 were refractory and remained thin. Subendometrial injection of PRP in the subendometrial niche using ovum pickup needle is done, and blood sample, you take 20 cc blood and make the PRP injection in both layers, anterior and the posterior, is done. The outcome among the 11 cases, 5 showed improvement in endometrial thickness. 3 of them got FET, 2 drop out, no pregnancy. Remaining 6 cases is still having their embryos frozen. Now I just want to present one of our case. We have been doing regularly PRP in endometrium. This is one of our case where this girl was used to come to me when she was 17-year-old, and we diagnosed her premature ovarian failure. She had for 2 or 3 years she had regular menses. After that she stopped having her periods. So AMH was done. AMH was 0.005, and this is her uterus. You can see the uterus size is small and the endometrium is pretty thin. Now this young girl was used to come, she was used to take hormones on and off whenever she wanted period. Now she got married and she is 22 years of age, and she presented that I want to conceive now, so what are my options? So we did talk in length about like ovum donation. We can prepare your uterus, but you might need ovum third party reproduction. So all of that has been talked about to her, but she said, doctor, let's try a PRP, what you are saying. So we did PRP. How the PRP is done, where it is, you prepare the sample of PRP, take a ovum pickup needle, and through ovum pickup needle, you can see here in the subendometrium, in 3 or 4 places, you inject small volume of the platelet-rich plasma, and then you have to come out. Suppose if you are doing your tubal patency test or other thing, please do not do after doing your PRP. Whatever you have to do, you do it before, because after you have injected, you are not supposed to do. Otherwise, the things, though you are injecting it subendometrial, it may get flushed out. There is a trick to do how you do PRP through ovum pickup needle, because sometimes if you're not practiced it before, it's good to practice it beforehand on a used needle. Otherwise, the material which you are injecting may come out from the other end. So that's a very technical thing, but it can be very well done by those who are doing hysteroscopy regularly and those who are doing ovum pickup also. So I think IVF consultants are a combo of endoscopy plus IVF, so they can very well do the PRP. And this is our patient after the post PRP. We did find that her endometrium is quite rich and it is an increased blood supply in the endometrium. So PRP, I just wanted to really make it short because we already heard a good lecture on thin endometrium. Just wanted to give little practical tips on PRP, that it can be done and it is found to be useful. So, just to conclude, it is a potential tool for those with recurrent implantation failure, but it is not an option right now. Do they say that you can do it in the male infertility as well? But it is not still an option because not well tried. So, thank you very much for patience listening. And I wish you all a very happy new year. And please support me for my Foxy presidential candidature. Thank you very much.
Thank you, Archana.
Thank you.
As always, crisp and backed by beautiful images and videos. We would like to have chairperson's comments on the talk.
Yeah.
Thank
Thank
you,
you.
Dr.
Thank you.
Archana. Brilliant talk, and how you showed the sub-endometrial infiltration, that was really good. So, is it like 1 ml you use it on all the 4 walls, or how would you do it? If you could tell me that, Dr. Archana. Not a mute. You are on mute, Archana.
Ovum pickup needle is too long. Yeah, it is very long. So it might get filled with your 1 ml PRP. So what you have to do, you have to take a little more volume and then you have to empty it because you don't want to inject the air as well. So you
Yes.
have to fill the whole length of the needle. If you can imagine your ovum pickup needle, so fill it full, and then because unless you have a good volume of PRP, so we take 20 ml and then you may prepare the PRP, and each side you have to see that 1 ml is injected in all four sides. So not 1 ml, because out of that 1 ml, because some will get flushed out also, because when you are doing a hysteroscopy, there is a fluid also going to distend the uterine cavity. So if you
Yes.
have a very small volume, you are injecting, it may get the flushed out. So you have to be little over in your volume rather than under volume. So
Okay.
make a good 4 to 5 ml of PRP and inject at 4 different places with a good hysteroscopic vision.
Okay.
And
Okay.
then
Yeah.
don't do any procedure, like if you have to take like endometrial biopsy or PCR, TB PCR or anything, because you might undo the procedure what you have done.
Yes.
Mm.
I think very rightly
Yeah.
said, Dr. Archana. I am also performing a lot of PRPs and good results are seen. The technique was explained is very nicely done. I know where it is written like that. The way ovum pickup needles are being used and the volume has to be adjusted according to the length of the needle. And very important tips, as you explain also, I also use the three-way cannula to stop the backflow.
Backflow.
Actually, if you increase the pressure, there will be a backflow. You have to avoid. Otherwise, the PRP get diluted and the things get wasted. So backflow and during injection, release the pressure. They decrease the pressure. That is one good technique. Like you can have a better injection. As soon as you inject and you are taking it out to avoid regurgitation, you increase the pressure. That is how we can just keep the PRP stay in the subendometrium without any spillage. So it's a wonderful way it's being developing and talked about. And I think Matt, you can write the paper on that good presentation so that we can have the good literature on this. Thank you
Thank
so
you.
much. Thank you so much
Thank
for
you,
the
Dr.
wonderful
Shilpi. I think it is important to have a practical points, because what happens, we all talk about PRP, but how to inject it, how to do, because in initial days we have also made the mistake. We have seen that it comes in the reverse direction, like how you do ovum pickup. It comes in reverse direction, so you have to put your like thoughts like how am I doing it. So I took ovum pickup needle couple of times and just tried to inject it with the normal saline, and then developed, yes, you have to do it this. And three-way is a really good concept, what you have said, that you have to use the three-way stop. So thank you very much for your inputs
Thank
and
you.
patience listening and chairing the session for us and sparing your evening for this webinar.
Thank you.
Thank you
Over
Thank you,
to
very
ma'am.
you,
much,
Dr.
Dr.
Anju.
Archana, and
Thank you,
wishing
Dr.
you all the
Vijay.
very best with your candidature.
Thank
Yeah,
you.
yeah.
Thank you, Dr.
All the
Vijay.
best. All the
Thank
best.
you. Thank you so much.
I thank Archana ma'am and chairperson for their insight and
You.
wonderful talk by Archana ma'am with all the practical tips. Thank you, ma'am. Ma'am, shall we go ahead with the panel discussion if you
Of
don't
course,
have any
of
other
course,
questions?
of course, we have to go with the panel discussion.
Yes.
Yes.
So we are now proceeding with an interesting panel discussion, and we have a very good blend of fertility experts joining us from all the zones of India. So I now request Dr. Aditi, who is the master of ceremony, to introduce our moderator and panel. Can I have Dr. Aditi's CV, please?
Um, yes, ma'am. Thank you very much.
Aditi, can I introduce you before you start?
Okay,
I'm
ma'am.
happy to introduce you. Dr. Aditi is consultant obstetrician gynecologist at BSCS MG Hospital, Surya Hospital for Women and Children, and also Gleneagles Hospital, Mumbai. She has advanced training and certification minimal access surgery, and she interestingly also Society of Critical Care Medicine. She has number of research and publications to her credit. She is very academically oriented, and she has also won the Best Paper Award and multiple such other prizes. So I welcome you, Aditi, to take over as Master of Ceremony.
Thank you very, very much, ma'am, for your kind introduction. So we now move on to the panel discussion, uh, titled Implantation Battlefield Strategies to Build a Better Endometrium. This discussion brings together an eminent panel of clinicians from across the country, each bringing their rich clinical experience and diverse perspectives to this challenging topic. It is my pleasure to introduce our panel moderator, Dr. Mrinmay Dharmadhikari, Madam. Madam is the director and fertility consultant at Dr. Dharmadhikari's Silver Lining IVF and Endoscopy Center in Pune. And Madam is also a consultant gynecologist there, and she has done her MRCOG degree as well. We are pleased to have you as the moderator of our panel today, ma'am.
Thank you
Uh,
so much. Thank you, Aditi, for the kind introduction.
Thank you, ma'am. I'd just like to introduce the panelists as well. Our first panelist is Dr. Hasina Sheikh. She is an FNB trained specialist in reproductive medicine with focused clinical experience in infertility care. Thank you for joining us today, ma'am. We next welcome Dr. Jeevan M. Chaudhary, a reproductive medicine specialist with extensive hands-on experience in IVF, andrology, and management of complex infertility cases. We are pleased to have you on this panel, sir.
Thank you.
Our next panelist is Dr. Sarika Daifale, ma'am. Madam is a consultant gynecologist at Indira IVF Center and an assistant professor at Bharati Vidyapeeth Medical College, Pune. Thank you very much for being on this panel as well, ma'am.
Thank you so much.
Our next panelist, Dr. Shrija Rani, ma'am, a senior consultant with over 2 decades of experience, and she's actively involved in reproductive medicine and academic work. Thank you very much for being a part of today's discussion, ma'am.
Thank you, Dr. Aditi.
Uh, Dr. Aswati Nair, we welcome you, ma'am. She is an FNB trained reproductive medicine specialist with a strong clinical expertise in fertility treatment and evidence-based practice. Thank you very much for joining us, ma'am, today.
Thank you. Thank you.
We now welcome Dr. Vishwaja Bakshi. She is an obstetrician and gynecologist with a special interest in reproductive medicine and fertility care. She has also done her ICOG fellowship in assisted reproductive technology from Navroji Wadia Hospital in Mumbai. We're glad to have you with us today, Vishwaja.
Thank you, Dr. Aditi.
Uh, Our next panelist, Dr. Purnima Madam. She is affiliated with Rangadore Memorial Hospital and District Hospital Bellary and is at present at Bellary Health City. Thank you very much for being with us, Madam, today.
Thank you. Thank you.
We now welcome Dr. Ashwini Talpe, Madam. She's a laparoscopic surgeon and a fertility specialist associated with Progenesis Fertility Center in Nagpur. Thank you very much for being a part of this panel, Madam. Dr. Durga Vyatla. Madam is a consultant at Nova IVF Hyderabad with extensive experience in reproductive medicine and has multiple national recognition of clinical excellence. We are delighted to have you with us today. Our next panelist, Dr. Sujoy Das Gupta. We are the clinical director at Genome Fertility Center, Kolkata. He is an award-winning academician and a nationally recognized voice in reproductive medicine. Thank you very much for joining this distinguished panel, sir. So thank you very much, everybody, for being a part of this distinguished panel. I'd like to invite our panel moderator, Dr. Mrinmay ma'am, to take over the session now.
Thank you so much. I'll just start my screen sharing. Okay. Is my screen visible?
Yes, ma'am.
Okay.
We just need that full screen. Yeah. Yeah,
Yeah.
it is visible. Yes.
Okay. A very good evening, everyone, and a very warm welcome to everyone who has joined in today, especially all our esteemed panelists who have made it from all across the country. And I would like to thank Dr. Archana ma'am, Dr. Asha ma'am for the wonderful talks that they have already delivered. They were absolutely enriching. And I think we as fertility consultants unanimously agree that endometrial problems are a stumbling block when it comes to infertility treatment most of the times. And it leads to reduced embryo implantation rates, reduced increased risk of miscarriages, increased risk of recurrent implantation failures. We do have a number of pharmacological treatments which are now available, have stormed the market, I must say. Regenerative medicine has also made a very stellar entry on the stage, but are these really game changers? So without further ado, let's start with our first case. It's a very simple case to begin with. 26-year-old woman, primary infertility for the last 2 years, regular menstrual cycles, normal ovarian reserve. She previously did undergo 2 cycles of ovulation induction with timed intercourse, unfortunately not successful. Husband semen did have mild oligoasthenozoospermia and she was planned for her first cycle of IUI. Ovulation induction done with letrozole, 5 mg for 5 days. Single dominant follicle of 19 millimeters was seen on the 11th day. Endometrial thickness was 6.2 millimeters, triple layer. No previous uterine surgery, no symptoms suggestive of tuberculosis. So basically, my first question is, how would you define a thin endometrium? Would you say that a 6.2 endometrium in this particular patient is a thin endometrium? Can we start with Dr. Hasina?
Yes, usually less than 7 is taken as a thin endometrium in any infertile patient, and in FET patient, if it is less than 8 it is taken as thin endometrium.
Okay, so following up from this answer, a thin endometrium is the cutoff the same for maybe an IUI cycle, a fresh embryo transfer, and a frozen embryo transfer?
Yes, it is less than 7 is usually taken as thin endometrium only.
Okay, so usually what we say, what the studies say is that in a frozen embryo transfer cycle, the endometrium from 7 to 10 gives the maximum rate of positive pregnancies, after which it plateaus. In a fresh embryo transfer, up to 10 to 12 millimeters of endometrium gives a good response, after which again it plateaus. So, but for all general purposes, a thin endometrium is universally accepted as less than 7 millimeters, though there is no definite cutoff, but most of the literature uses a 7 millimeters as the cutoff because pregnancy rates significantly fall below this particular level. It's also important that we are all on the same page when we are measuring the thickness of the endometrium. It is the distance between the echogenic surfaces of the endometrium and myometrium in a sagittal plane or in the central longitudinal axis of the uterine body at the maximum thickness near the fundus. So coming to the previous patient is 6.2 millimeters, as you said, that would mean it is a thin endometrium. So what should we do for this patient, or should anything be done at all? Can I request Dr. Jeevan Chaudhary sir to take this question?
So this is ovulation induction cycle, and endometrium is 6 millimeter. As far as the previous history concern, I'm not aware about what about her previous cycle. So I'm judging this by this only information. This is the first time she has encountered 6 mm. So I'm not that serious about it. I can add ecosprin at this juncture, and maybe that would be enough for this patient as this is a triple line endometrium. I can add some information in the form of blood flow indices and actually how much blood flow is there. If it is near satisfactory, I'm not worried. But if it is happening repeatedly on
Correct.
a second occasion, I would like to investigate. So there are plenty of things to investigate from her history. I'm not getting any clue or
Correct.
any pinpoint cause of
Yeah.
being thin. So rightly from hormonal evaluation in terms of prolactin or thyroid also can have some impact, and basic other investigations can be done if it happens again.
So as sir rightly said, it is very important to check the endometrial thickness in her previous cycles as well. So in her previous ovulation study cycles, if the endometrium has reached a thickness of 8 mm on the day of trigger, which means that endometrium does have the potential to grow that much. So in this particular case, sir, would you like to delay the trigger? It's only 19 mm the follicle. She's
Yes.
day 11. Endometrium is 6.2.
So letrozole was given. It is nearly to the ideal size of the trigger, but I would
Okay.
like to wait for a day.
Yeah. So
There
one
is
of the
no harm
strategies is
in
to
a
delay the
day.
trigger to wait for the endometrium to catch
Yeah.
up. Okay.
Again, I would like to know about the history, whether she has hypomenorrhea. If she bleeds less, then that can be
History is
leading.
unremarkable, absolutely
Yes,
unremarkable
so we are
history.
not worried about the
Correct.
history.
Correct. Okay. So is quantity the only thing that we're looking for, or does quality also matter? Can I request Dr. Sarika to take on this question? When we say quality of endometrium, what are we exactly looking at?
Definitely, we are more into the quality because only the 6.5 mm doesn't give us a clue about the endometrium. The morphology of endometrium is also necessary to check whether it is a trilaminar or a isoechoic or a hypoechoic. This is definitely going to matter a lot. If even a 6.5 mm with a trilaminar gives a good pregnancy rate, but if the same value with an hypoechoic may have the failures. Definitely, this is a cycle which we just add the letrose. So definitely, we can wait for follicle to become 24 mm, and
Yes.
we can wait for 1 or 2 days to check the blood flow even, because that even the matters. So quality matters more than the quantity.
Correct. So when it comes to blood flow, as Dr. Sarika mentioned, endometrial vascularity, can I request Dr. Shrija to shed some more light as to how do we classify the endometrial vascularity and what are we exactly looking at, and how do we prognosticate this?
Endometrial vascularity definitely matters a lot, especially in FET and normal induced cycles. So it is type 1, type 2, type 3, type 4. Type 1 is at the basal layer of the endometrium. You see vascularity. Type 2 at the middle layer. Type 3 at the inner layer. And type 4 in the endometrial cavity. That is not seen. But type 3 would definitely, if she is having thin endometrium but trilaminar with type 3 vascularity, she has good prognosis.
Yeah, that's absolutely correct. So we check the vascularity and then we classify as to what zone the vascularity has reached. Zone 3 and 4 are the ones which gives the maximum pregnancy rate. So it is not only the endometrial thickness which is important, it is important to check for the endometrial and subendometrial vascularity as well. What about endometrial volume? Does anyone do it frequently? Any experience? Dr. Ashwati, are you measuring the endometrial volume to assess your patients on a routine? Like, what is the clinical application of this in your practice?
So I'm not routinely measuring the endometrial volume at the clinic. Once you have a good looking endometrium and the thickness is close to 7 mm or more, that is the thing that we usually look out. And if it is more than that and a good pattern and vascularity, we usually don't bother about such an endometrium. Only when it is on the lower side, then probably this endometrial volume also becomes a little questionable. And also here, I would like to mention that especially in those cases where the endometrial pattern is not regular, you have to think about volume very specifically, because
Yes.
volume is usually low in a very cicatriciated cavity, a past history of tuberculosis where you're expecting an Asherman's or in Sinec. In that case, the volume becomes important. And if there is a situation like that, I would definitely put on my 3D settings and do a 3D ultrasound, 3D transvaginal sonography, which will give me a better information on the volume,
Perfect. Yes.
but not
So,
a routine thing.
as rightly said, endometrial volume measurement is considered a potentially useful adjunct in certain cases like adenomyosis, intrauterine synec, or where the cavity appears to be smaller, but it is not a standalone predictor in infertility assessment. So, a volume of 2.5 to 3.5 ml does appear to favor a pregnancy in an IVF cycle, but again, we need to select our patients more appropriately. Okay, so anyone can just summarize the Applebaum scoring. Is anyone actually doing it routinely? And what is the significance? Dr. Vishwaja?
Yes, ma'am. Actually, we do not do it routinely because of the tedious nature of the scoring. But for academic purposes, we do follow it in a few patients as well. So it uses, as rightly shown by you, it's the endometrial thickness, the layering, basically triple line or how thick the layering is, and the blood flow, the zones we see for all the patients, and the Doppler flow we usually tend to do just before implantation, like in the transfer cycles, and the ecogenicity. So,
Yeah.
because of the tedious nature, we usually
Correct.
don't end up doing it for all
So
patients.
basically, all in all, it is important to assess the quality of the endometrium and not just the thickness. So again, I think after all the answers, I'm sure all of us would proceed with the IUI cycle and not cancel this. Any modification to the treatment at this stage, considering that she has been growing endometrium consistently in her previous cycles, and this is the first time. Maybe it is too early to assess 6.2 mm, good subendometrial vascularity. Anything to modify at this stage? Dr. Purnima?
I don't think so. We need to modify anything because, as seen, the endometrium is triple trilaminar and the blood flow is good. Quality is good. So we may go ahead with the IUI or IUI, I feel.
Correct. So,
So
madam, when
maybe
would you
next cycle,
investigate this
if
patient? When would you want to investigate her for a thin endometrium? When would you say ki, no, something is amiss in her endometrium? After how many cycles? Do you have any specific protocol that you follow that after 3 cycles, okay, something needs to be done, or 2 cycles? How would you go ahead?
Actually, after 2 cycles, I would like, I mean, 1 cycle, and in the second cycle again, if it recurs, I would like to investigate her. Uh, really need to know what is the cause for her thin endometrium.
Okay, so what specific causes would you be looking for, and how would you investigate her?
Specific causes like any history wise, again, any history like chronic endometritis, any history of DNCs or medical management for any abortions, would like to know. And then hysteroscopy, and also 2D ultrasound, 3D ultrasound, to confirm them, and would proceed with the hysteroscopy to see for the features of any chronic endometritis. Yeah.
Okay.
And
Okay.
then
Thank you so much for that, ma'am. So a key takeaway from the first case is that a triple line pattern and adequate subendometrial blood flow are associated with better implantation, even if the thickness is modest. So it is a functionally reassuring endometrium. So that is one of the most important key takeaways here. Coming to the second case,
Ma'am, can
she's
I
a
come in
sorry.
here? There was a question pertaining to this first case
Okay.
from Shazia Rashid in the audience. Can we start her on ecosprin and estrogen?
Okay. Does any one of the panelists want to take that up? I think Dr. Jeevan sir had mentioned ecosprin. So do you want to shed more light on the
Yeah,
same?
there is no harm in adding this ecosprin. So if at all I want to intervene, that will be the only thing I would like to do. The endometrial quality also depends upon the quality of the follicle. What amount of estrogen is generated by the follicle. So
Right.
if the day of menses of the patient is too early, maybe 6, 7, 8, that also tells us that it might be a uh, uh, abnormal growing follicle in terms of cyst maybe forming or low quality of the follicle, and we can think about that also, but this is the first cycle, so I am not uh, I'm not jumping to any conclusion here.
Correct. Any of the other panelists who would differ on this aspect of adding ecosprin in this very cycle? Anyone who would not?
So I would
I
add
would not want
estrogens.
to add actually. I would not want to add. If it's a good endometrium with
Correct.
good vascularity, why to unnecessarily add ecosprin? I might add a estrogen pill, but in the first cycle, I would rather delay the trigger, and we can very, closely monitor the follicle and take it till a good 22 mm, and then give the trigger. And I think this endometrium should respond.
Should grow.
You know,
Correct. Okay.
But
yeah.
Thank you so much.
just one question, what is the harm in adding ecosprin,
So,
I can say?
see, there is no
Even we
harm as
can
such.
add
It's a blood
sildenafil
thinner, as
citrate
we
in the
all know.
cycle.
So, why unnecessarily add is the question here. So,
So to answer that question, I have seen
That's why I use the word, if at all I want to add, that would
yeah.
be ecosprin.
yeah, no,
That's
sir,
it.
absolutely fine.
Even
Everybody
there
has
is
a
no
different way
harm
of
in adding
practice.
sildenafil citrate.
At
Yes.
this stage, there is one study in 2005. I'm not able to remember the name, but it was stating when to stop sildenafil citrate. In case of IVF, it was stating at least 5 days prior to your transfer, you need to stop. So I believe we need to keep in mind that aspect also. Uh, what they actually I will not be able to recollect why they wanted to stop that sildenafil prior to transfer or any intervention, just like IUI or TI. But we should be aware about this, that sildenafil should be used to the duration and the timing of the sildenafil should be defined.
Correct. So there are a number of adjuvants which we can add. There is no harm in adding, but there are
Yes.
so many of them. And I think a patient selection is very important because we cannot possibly give all adjuvants to all patients hoping that one of them will work, which is why the panel discussion. So moving on to the second case, a 32-year-old, primary infertility for the last 4 years, regular cycles, normal hormones, unremarkable surgical medical history. IVF was done for severe male factor infertility. 3 euploid blastocysts were available for transfer. Now, a frozen embryo transfer was started with hormone replacement therapy. We started with 4 milligrams per day. On the 7th day of estradiol, endometrium was only 5 millimeters. So we increased the dose of estradiol to 6 milligrams per day. On the 13th day of estradiol, the sonography, as shown in the picture, endometrial thickness was 5.3 millimeters. Now, my question to Dr. Ashwini is, what should we do next? It's only 5.3, it's the 13th day of estradiol. What would be your next course of action? Is Dr. Ashwini here?
Hi.
Yeah.
We should have increased the dose on like saw it on day 7, day 8. At that time, if the lining is very thin, so I could have made it like 8 milligram per day.
So how do you decide that?
So it
How
depends on
much to increase?
See, it depends. If you see initially the lining, like previously, how was the lining of the patient? So you should evaluate before also, like previously the whether lining was thin only, then with the starting dose only, you should start with the higher dose. But if it is a first time, then definitely the lining needs evaluation because 5.3 on this much dose is quite thin lining. So there is a high possibility that it could be inherently thin lining. So basically, it needs evaluation and whether she is on what type of like estradiol, valerate, or hemihydrate before
So what
that.
is your preference, valerate or hemihydrate?
I go with valerate.
Okay. Any specific reason, or have you experienced not so good endometrium with hemihydrate? Any specific reason, or no specific reason?
So I'm getting good result with it. That's why I'm going with it. If
Okay.
some
And what about
cases
the other
are
hemihydrate?
refractory to that, then I switch to hemihydrate. So
Okay.
if I suspect the receptor pleomorphism in that patient, then I go to hemihydrate.
Okay.
I'm not using hemihydrate for each and every patient.
Okay. And what is your starting dose for endometrial for frozen embryo transfer cycle?
So if I have down-regulated the patient, then the dose should be on the higher side, definitely. If you are completely down-regulated, then dose should be according to your previous cycle. You just see previously how was the endometrium. Then I generally start with like 212 or 1 TDS, depending on previous lining.
Okay. So in this particular patient, as you said, if we had increased the dose up to 8 milligrams per day, and on the 13th day, you see it is 6 millimeters. So
Yeah.
for how much longer would you give the estrogen, and how much more would you increase the dose before saying that this is not responding?
See, I can give estrogen before transfer till like before starting progesterone, we can extend the phase till day 14, day 15. So generally I can wait till day 15, day 16, and we'll evaluate about the maximum thickness. So we can go for add-on therapies like PRP, stem cells, and growth factors like GCSF. If we see in the initial phase only the thin endometrium, we know this is thin endometrium, inherent thin endometrium, then we have to use adjuvant in this.
Okay.
So along with sildenafil, arginine, so vasodilators, everything has to be started along with that if it is thin endometrium.
Okay. So I'd like to ask now Dr. Sujoy, uh, what would you do? Would you increase the dose of estrogen by how much and for how long?
Okay, I'm sorry, I'm traveling, so that's why there may be some background noise.
It's okay. We
First of
can hear
all,
you clearly, sir.
yeah. So first of all, I need to see the urgency of the patients, because sometimes the patients are coming from remote places or from abroad. They need to complete the cycle. Means they want to do the transfer in this very cycle. In that case, I will increase the dose gradually, 10 maximum to 12 milligram. Means the 6 tablets, means 12 milligram total estradiol. And I've not found any significant difference between hemihydrate and valerate. But along with them, I have sometimes found that adding this gel, transdermal gel of estrogen, that sometimes help, and along with that, sildenafil. Sometimes I found that in some women, if we wait till say 25, 26 days, sometimes endometrium thickens. If
Correct.
the woman at all wants to do the transfer this cycle. Otherwise, if I find that usually day 20 to 23 there is the endometrial thickness is less than 7, I usually transfer the cycle, and next cycle I will consider doing natural cycle or maybe the stimulated cycle like using letrozole. Of course, in that case, I'll see what was her endometrium on the day of trigger in the fresh cycle. Because
Absolutely.
if endometrium was good on the day of trigger, then only we can go for natural, modified natural, or stimulated cycle. Otherwise, in the next cycle, from the very second day, we have to increase the dose. Say maybe we have to start from 12 milligram per day from day 2.
Okay, thank you so much for that, Dr. Sujoy sir. So can I quickly have a poll from all the panelists with just the maximum dose of estrogen that you give and maximum number of days of estrogen which you have given so far? Just in two sentences. So, Dr. Hasina?
Maximum dose is 12 milligram and
Okay.
maximum dose is around 12 to 14 days.
Dr. Jeevan, sir?
Same, the 12 milligram, and I usually wait till 17, 18. But as Dr. Sujay has suggested, if such is the case that this is the very cycle they really want to go ahead with the transfer, then I can consider few more days to add.
Dr. Sarika?
Yes, 12 milligram, and I usually wait till 15 or 16th day. And if there is no hurry, I usually cancel the cycle.
Okay. Dr. Shrija?
I usually don't go beyond 14th day. By 14th day, the endometrial thickness is not good, and the lining is not triple layer, and vascularity is not good. I usually cancel the cycle, and I've never gone beyond 12 milligram.
Dr. Ashwati?
So I beg to differ here. When I have usually gone up to 12 milligrams orally, and whenever I have had to go beyond that dose, I have added it vaginally. The same tablet that we use orally, that same tablet can be used vaginally also. And I don't know if there are research papers on this, but practically this has worked very well. This vaginal estrogen that we give. So the same tablet, I have added like two vaginally morning and two vaginally at night. Okay, so that
Okay.
adds up to nearly 8 milligrams more vaginally plus 12 milligrams orally. So this is the dose that I've given. And if at all you ask me, I mean, I have gone maximum beyond, like not beyond 20 to 23 days, waiting till then for the endometrium to get ready. But research says that you can, even papers are there which says you can, in a HRT cycle, because the ovary is quiescent, there is no follicle growing, you can go up to even 35 days with this high dose of estrogen. So, but I have restricted myself to around 20 to 23 days, not beyond that, because somewhere down the line you start thinking about endometrial embryo
Correct.
asynchrony. And in spite of developing a good endometrium, you don't want the transfer to fail just because of that reason.
Correct. So, Dr. Ashwati, you're right. There have been papers in which they have given estrogen for up to 60 days even.
Yes,
But again,
yes.
there are no papers.
35 to 82 days, yeah.
Correct. So there are no
Yeah,
studies which have actually defined that,
correct.
it's safe enough to give estrogen only for so many days. Again, as you
Yes,
said,
yes.
rather than increasing the dose of oral estrogen, as we all saw, I think the general consensus is 12 milligrams per day. Instead of increasing the oral dose of estrogen, adding a vaginal or a transdermal route reduces the risk of estrogen-related complications like on the coagulation profile or even on the liver for that matter, because it bypasses the first pass metabolism.
True, true.
So coming to Dr. Vishwaja, what about you?
Yes, we also usually give up to 12 milligrams, and
Okay.
we give till 14 or 15 days. But even if we cancel the cycle after that, we usually follow the trend up to where it is going. And we may not transfer in that cycle.
Okay. Dr. Purnima?
Usually I don't do IVF. I practice up to IUI. So I
Okay.
have done up to 12 milligram maximum dose
Okay.
for 12
Okay.
days.
Okay. Dr. Ashwini?
I generally give up orally 12 milligrams and I use transdermal gel also. So twice a
Okay.
day a
Great.
gel. And some cases I use vaginal also. It depends like how patient is responding.
Correct. Okay.
And maximally till 14 days, 14, 15 days.
Okay. So there has been a large clinical trial of almost 8,300 embryo transfers in which they have compared a constant dose that is starting from a very high dose from the beginning compared to increasing doses, like starting with 4 milligrams, increasing to 6, 8, 12, and so on. And they have found that there is no difference in the live birth rates. Again, they have compared oral estrogen only with only transdermal estrogen gel. And again, there was no difference in the live birth rates. So basically, your treatment protocols should follow patient convenience without affecting the success rates. There is also a very good paper on thin endometrium problem in IVF, which they have shown that transdermal estrogen, as Dr. Ashwati also mentioned, gives a similar pregnancy and take-home baby rates as oral estrogen. Addition of transdermal or vaginal estrogen is to be considered if adequate endometrial thickness is not achieved with oral estrogen alone in order to decrease the adverse effects of oral estrogen. This has been corroborated by H3 as well. Again, coming to the other side, effect of estrogen dose and duration in programmed frozen cycles on obstetric outcomes and placental findings is something which, we need to think of. It is a food for thought, because this paper specifically says that there could be increased incidence of low birth weight babies or placental complications in those in whom a higher dose of estrogen has been given. But again, there was a confounding factor that you give high dose of estrogen only in those who have a poorer endometrium. So, but again, we need to have more studies on the adverse effect of estrogen on our pregnancy rates. So what we did in this particular patient was we increased the dose of estrogen to 10 milligrams per day, continued for 17 days. She had a good 7 millimeter triple line endometrium, good vascularity. Again, the quality was assessed. Progesterone was started, single blastocyst transfer was done, and the patient conceived. So a review of estrogen treatment regimen is the first thing that you should do if you have finding a thin endometrium. And this has again been corroborated by ESHRE good practice recommendation in cases of recurrent implantation failure. So coming to our
Dr.
third case.
Mrunmayee, can I add
Yes.
one thing? Can I
Yes,
add
please.
one thing?
Yes, sure.
So when you were discussing about what dose is a good dose to start for a patient, I think we are in that era of frozen embryo transfer. Most of us prefer doing a frozen embryo transfer. So I think the the cycle when we are stimulating the ovary during our ovarian stimulation phase of the ICSI treatment, at that time only we get an idea how good the endometrium is.
Correct.
So, most of us try to just measure the follicle, keep a look at the endometrium. You definitely have an idea what is the ceiling you can hit. And accordingly, when you prepare the same patient for a frozen embryo transfer, you can decide your starting dose based on what you hit and how easily you could hit.
Not only starting dose, even the ending dose, like how many more days should you continue? Because
Should you
what is the
continue?
potential of the endometrium in a stimulated cycle, and that gives you kind of the best endometrium which can possibly be formed in your IVF stimulation. So thank you for that point, Dr. Ashwati ma'am. So third case, 37-year-old primary infertility, regular cycles, unremarkable history otherwise, AMH 1.5, ICSI was done for male factor. 2 euploid blastocysts are available for transfer. So we did her HRT FET cycle. Unfortunately, it was unsuccessful. Her endometrium in that particular cycle reached 6.5 millimeters triple line. Vascularity was up to the zone 2. So now this patient said, I have only 1 blastocyst left. Let's do a hysteroscopy. My first question is, what are you expecting in your hysteroscopy? What could be the findings responsible for thin endometrium? Can I start with Dr. Hasina again? Let's start again. Hysteroscopy findings in a case of thin endometrium.
I think she's got disconnected.
Okay. Can I move on to Dr. Jeevan? Dr. Jeevan, sir?
This is 6.3 millimeter and it is
6.5, yeah.
borderline thin, I can label.
Okay.
So I'm not expecting too many things when I'm doing hysteroscopy.
Okay.
So when things means any troubling factor is there, we can resolve it during the hysteroscopy. Adhesions can be dealt with adhesive lysis, and I would like to look for the endometritis panel. If something is there causing this endometrium not to function properly, I would like to know before transferring the embryos. And again, second thing, uh, as again there is a very much discussion about probiotics and prebiotics. So I would like to look into the matter that adequate dosage and duration of pre-probiotics have to be given to this patient. These two things prior to the transfer. Then your hysteroscopy is also unremarkable. So what should
So
be my protocol?
hysteroscopy, on a hysteroscopy here, I would like to highlight that just because endometrium is 6.5 millimeters does not mean that it is a good endometrium or it is not that thin. Again, we're talking about quality. So that is why, since we have only 1 blastocyst, patient is going to ask you, what are you going to do differently? hysteroscopy is one of the things in our armamentarium where we can diagnose chronic endometritis. All patients of chronic endometritis need not have a thin endometrium, but they will have a lower
Yeah.
receptivity of the endometrium leading to
Even
failures.
borderline thin endometrium can be harboring these causative organisms. So
Absolutely,
that
absolutely.
can be the cause of failure also. So
Correct.
we need to address it, and
Yeah.
it is not like that every endometritis will present with thin endometrium.
Correct. So as
So
Dr.
we
Asha
should
Madam
be open
rightly
enough.
As Dr. Asha Madam rightly elaborated in her talk, that findings like micropolyps, hyperemia, fibrosis, scarring, these are some things which can be diagnosed on hysteroscopy and can be treated as well in the same procedure. And
Same
maybe
setting.
we can give the patient a better option in her next embryo transfer cycle. So now, when planning her repeat FET cycle, we have one blastocyst left, and the patient is going to ask you, what are you going to do differently this time? So can I request Dr. Sarika as to what can you do differently? Anything else you would try in this particular patient?
Uh, we can try for hysteroscopic PRP even in this patient, because as only one blastocyst is left and as your history is giving us a clue that her endometrium thickness is around 6.5 mm, which is absolutely a light borderline. We have to check her previous history too, because this IVF has been done only for the male factor as your history. So we must know about her cycles, which has been prior, how's her endometrium, what's the quality, how it goes, and this all help us. PRP, yes, definitely, that is a one of a established thing which helps the blood flow as well as the endometrial thickness. So as only one blastocyst is left, we can add all the adjuvant even in the same cycle. We can go for a proper modest doses of estrogen and PRP, which is helpful for us.
Okay, so I'm just going to add one bit of information now in this history and then ask Dr. Srija as to what she's going to do. In her stimulation cycle, the endometrium grew up to 8 mm. So now what would you do differently, Dr. Srija?
So rather than an FET cycle, I would go for a natural cycle or a modified natural cycle.
Yes. Yes.
So if required, I can start estrogen, and that would be the best thing. I think this for the suitable for the patient.
Yes. So now modified natural cycles, again, they have a lower pregnancy complication rate as well because of a functioning corpus luteum.
Yeah.
And it is more patient friendly with respect to the cost of medications as well. So modified natural cycle is something which we need to think of in order to give a better quality of endometrium. Other than that, of course, the adjuvant therapies, there are so many. I think I would like to ask each panelist what is their go-to adjuvant therapy when they encounter a thin endometrium. What is the dose in which you would start it and for how long would you continue it? Dr. Ashwati, can we start with you?
Yeah, so in that particular case scenario that you had described, one thing
Yeah.
that probably we just had the blood flow till zone 2. Okay, so now that is something we have to understand, that all these drugs that we are taking orally, be it estrogen also, it is delivered through the to the endometrium through these end vessels only. So
Right.
if the blood flow of the endometrium is less, definitely the effect of estrogen that is coming on the endometrium will be less. Of course, after the second thing that you mentioned, my mode of preparation would again be to go with a natural cycle or a modified natural cycle preparation. And if you ask me, out of these five adjuvant therapies, if you ask me to pick my choice, just one, then it would be aspirin low dose. And I would like to start in a dose of 150 milligrams per day. And of course, I would continue it till she completes her first trimester at least.
Okay, perfect. So aspirin is your go-to drug. What about Dr. Vishwaja? Dr.
Actually,
Vishwaja?
except for growth hormone, we use all four, especially in cases where there is recurrent thin endometrium.
Okay. So
So,
can you elaborate on the dose of sildenafil that you give, the route, as well as for how long would you continue in case the patient does conceive?
so we usually give 25 milligram per vaginally,
Okay.
twice, once in the morning and once at night. And we usually do continue it till the um dating scan, because then usually she starts complaining of vaginitis, and also that is the first drug that we stop.
Okay. Okay. What about GCSF? Anyone who's giving GCSF, Dr. Purnima, are you giving GCSF for your patients with thin endometrium? Any
No, no
experience on
idea.
that?
No idea.
Okay. What about Dr. Ashwini?
I'm using GCSF, but
Okay.
I'm using initially we used to use it intrauterine,
Okay.
but the lining was not that responding as like subcutaneous is giving better result as compared to intrauterine. So nowadays I'm switching it to subcutaneous GCSF.
Okay, so there have been papers which have shown that giving GCSF intrauterine on the 10th day as well on the day of embryo transfer or on the day of HCG trigger, depending on what cycle you are doing, has given marginally better or statistically significant improvements in the pregnancy rate as well. So, but of course, we do need larger studies to make this a guideline at the end of the day. Okay, anyone using growth hormone? Dr. Sujay, can you elaborate on growth hormone, whether you're using it or not, or any insights on the same?
No, I have never used growth hormone for this purpose. I have
Okay.
sparingly used PRP and
Okay.
this GCSF in maybe 2 or 3 cases, because I'm
And your
particularly
result? Was it good?
I'll say out of 3 4 cases, one patient conceived, but
Okay.
I usually reserve the adjuvants for resistant cases where I cannot use this natural or stimulated cycles, like women with premature ovarian insufficiency. Otherwise, I am particularly biased in this case towards the natural, modified natural, or this stimulated cycles, because I found that the results are better than trying different adjuvants and increasing the dose. But
Right.
I use this, and but other cases I use sildenafil very frequently, and I found with sildenafil, along with increasing the dose and with this transdermal estrogen, this gives better results in many cases.
Okay. So there
Just
has
one
been
thing
a
to add
yes,
regarding
yes, sir.
Dr. Sujoy.
Yeah.
He has mentioned, and he is very relying on modified natural or natural cycles. So even with natural and modified natural cycles, we are facing problems. Means
Of
these
course.
patients are not less. So we need to consider other adjuvants in such cases, and we should feel free to consider one or more of the options of the adjuvants also. Just like
Absolutely.
PRP is getting established, the second option again is GCSF, and PRP, as some people like me are preferring intrauterine instillation. In that case, GCSF has to be given subcutaneously, just because uh, far more patients are means those who are failed IVF cycles, 3 4 cycles. There, most of the times the problem is with endometrial tolerance, and here you need to try everything out, and then you can be able to generate some better quality of endometrium. So it will not be a one-way traffic. We need to
Correct. Correct.
consider all these things when some tougher cases are there, and they are not lesser in number right now.
Right. So let us look at what evidence has to say. So this is a meta-analysis, network meta-analysis and systematic review of all the efficacy of the adjuvant therapies in improving endometrial function. And this particular study found 3 out of 5 therapies showed statistically significant improvement in the thickness, that is sildenafil, PRP, and GCSF. There was statistically significant improvement in clinical pregnancy rate with the help of PRP, GCSF, aspirin, growth hormone, with PRP showing maximum improvement. So all in all, this is just a summary. The endometrial thickness could be improved. The biochemical pregnancy rate by PRP was slightly improved. Clinical pregnancy rate was also higher. However, what we are most interested in, that is the live birth rate. None of these showed a statistically significant improvement in the live birth rate. So again, it brings us back to what Eshre has been saying, that none of these are recommended until and unless we have more evidence-based and more robust data to corroborate these as guidelines. Coming to another important aspect, that is microbiome profiling, as Dr. Jeevan Chaudhary had mentioned previously, use of pre and probiotics. So microbial dysbiosis as a cause of implantation failure is still a dynamic area of research. There have been some studies which have shown a clear-cut association between the two, but again, we do not have specific guidelines for the same because of the lack of larger randomized controlled trials, which will exactly tell us what is the dose, the duration, and what is the actual impact on pregnancy rates. So as of now, ESHRE does not recommend the same, neither do any of the other main guideline forming bodies. So again, a quick poll question. At what minimum thickness of endometrium have you had a positive pregnancy, and below what thickness would you cancel the transfer? So just two answers: minimum thickness and below what thickness would you cancel the transfer. Dr. Hasina, is she back? Dr. Hasina, are you here?
I don't think she joined back, ma'am.
Okay, no problem. Dr. Jeevan, sir?
So least thickness with which I got pregnancy is 5.2,
Okay.
and it got aborted, unfortunately.
Okay,
But
that's also an important condition.
I'm not very stringent regarding this thickness. Other parameters do play a part, and we need to
Right.
consider all of them.
Okay.
Canceling the transfer, maybe 5.5.
Okay.
5.5, but I needed to transfer the embryos in that case with 5.3, just because that was triple line, and patient was pushing me for the transfer, and we did it. Sac was evident, but after that it didn't go.
Unfortunate. Okay. Dr. Sarika?
Minimum thickness, which I prefer at least 8 or 8.5 with all the parameters, with the blood flow and everything. Yes, definitely below 7, I usually cancel because I having less patient data to tell this. But yes, definitely below 7, I would not prefer to go ahead with the transfer.
Okay. Dr. Shrija?
To be honest, I haven't had a pregnancy when the endometrial thickness was less than 8 mm. If the thickness is 6.5 or less, I would cancel the cycle.
Okay. Dr. Ashwati?
I've had a live birth at 6.2 millimeters, but if it is less than 5 millimeter, I won't be confident transferring.
Okay. Dr. Vishwaja?
We have had a live birth at 7 mm, and we usually aim for more than 8, but it depends on a lot of factors and the desperation to transfer.
Okay. Dr. Purnima, ma'am? Okay. Dr. Ashwini?
So I got recently one of my patient with the 6 mm. She got positive and now she is around 6 weeks. So continuation phase is ongoing. But frankly speaking, minimum thickness is around 6 millimeter. I got positive result. And my cutoff is around 6.5.
Okay. And Dr. Sujoy?
Yeah, I got pregnancy and live birth in 3 cases with 6 millimeter. In 1 case, it was second cycle, and 2 cases, first cycles. But all of these women had this thing like premature ovarian insufficiency. So I did not have any other options apart from increasing the dose of estrogen. And all of them had very good triple layer endometrium, even when it was 6. So then I transferred the embryos. But of course, after counseling, I had lots of discussion with the patient that because we don't have any other options, so we are going to do. Then the patient said, "Okay, let's give a try."
Correct. Correct. So thank you so much. The next very important topic is something which, I mean, no panel discussion on thin endometrium can be complete without talking about genital cocks. So in a patient with refractory thin endometrium, when would you actually suspect genital cocks? Can we have Dr. Jeevan, sir? Dr. Sarika?
Definitely, it is on the history first. If
Right.
the history of a menstrual cycle, particularly in terms of the flow and history of contact, obviously the history of previous, we usually have a history of a past history about a pulmonary TB. If any family members who is having the tuberculosis or ongoing, because in India the tuberculosis is very rampant, so by default we are been to ask these kind of questions right from our UG or undergraduate training. So definitely hypomenorrhea or amenorrhea followed by scanty cycles, particularly those women who are giving the history. We usually screen them during their. I usually do a day 20 screening of a woman, particularly to check the endometrium. If a woman is having the good hypoechoic, hyperechoic endometrium around more than 8 post ovulatory phase. So definitely this gives us a clue about two things: whether she is ovulating, that's the one thing. The other thing is that her endometrium goes beyond that, and we will understand that whether this flow is subjective or it's objective. If a woman, though she is giving, most of the women are coming up with the history that they are having less flow because her age is another the more factor importantly. But in terms of Cox, yes, definitely history is more important. And once we go for that, then the investigation comes up.
Correct. So other than history, we have ultrasound. Intrauterine synechic can be diagnosed even on ultrasound now with 3D ultrasound or saline infusion histogram. Refractory thin endometrium again increases the suspicion of genital Cox, especially in India, and a T-shaped uterus on a 3D ultrasound. Again, histolaparoscopy also is patients sometimes may not have any history at all. But on histolaparoscopy, it is a very obvious picture of genital Cox. So again, histolaparoscopy can help in the diagnosis. So because tuberculosis is a paucibacillary disease, it is usually difficult to diagnose. So even with an endometrial gene expert or a TB PCR, which we are sending, how many of us have actually got a positive report in patients in whom you're not really suspecting, but you have sent it because of maybe recurrent implantation failures? Anyone has had a positive TB PCR report with no previous history of pulmonary Cox contact, but just a thin refractory endometrium. So the sensitivity of TB PCR is actually 75 to 80%. So some of the cases are missed. So we can safely say that a TB PCR, if it is positive, it is suggestive of tuberculosis, but a negative report may or may not really tell you the diagnosis. So other than that, so laparoscopy findings, we can have bilateral hydrosalpinges, lead pipe rigidity, dense intrauterine adhesions, T-shaped uterus, micropolyps, chronic endometritis. But my main question here, a patient with recurrent implantation failure, refractory thin endometrium, none of your adjuvants have worked, PRP has not worked, you do have maybe 1 or 2 blastocysts left. Would you advise this patient for a prophylactic anti-tuberculosis treatment? Can I start with Dr. Sujoy? Dr. Sujoy, are you there? No, I think we cannot hear him. Dr. Shrija? Okay, yes. Yes,
sorry.
Dr. Sujoy.
Yeah, in that case, I'll be a little bit skeptical because very, very recently in Kolkata, there was a medical legal case sued against one of the physicians because he started the ATD empirically and the patient developed fulminant liver failure. So in that case, I usually consult with the pulmonologist uh, regarding this, because if I start ATD empirically, if everything goes well, fine. But from medical legal point of view, if the patient develops any complications, then it's very difficult to stand nowadays.
Okay. So medical legal aspect is one of the aspects which we need to think about, because we need to report all the cases on whom we are starting anti-tuberculosis treatment. Dr. Ashwini, what about your experience on this?
Definitely empirical AKT will help, but we need to judge the patient. How is he, whether he will tolerate, whether she will tolerate or not. So accordingly, with the notification, you can start while consulting physician, you can give AKT. So if the 1 or 2 embryos are left, definitely I would go for AKT, empirical AKT.
Okay. Well, Dr. Vishwaja, is she here? Dr. Vishwaja, anything you want to add to this? How would you counsel this patient that you are going to need to take anti-tuberculosis treatment for 6 months without definitive evidence of tuberculosis in a society where tuberculosis is stigmatized?
Yeah, I mean, it's definitely a difficult news to share with them. The acceptability will also be a problem.
Correct.
And I will definitely have second thoughts on starting AKT as well for this patient because we don't know till what level the damage has been done and if it will definitely be resolved by the AKT that we are giving.
Okay. Dr. Ashwati, anything you want to add as to how would you do it? Would you not? How would you counsel the patients? Have you had previous patients in whom it has worked or not worked?
No, I'm not somebody who would give prophylactic ATT to anybody.
Okay.
Because as Dr. Sujoy rightly mentioned, there is a big medical legal clause to it. So, in our practice, we definitely find some patients where, you are in that dilemma whether to start or not.
Yeah.
I usually think it is wiser to involve a pulmonologist or, what I do, I have like the place where I practice. So near my clinic, I have 2, 3 government hospitals. I just send them to their DOTS unit with all their reports, write a good clinical summary and let them take a call on this so that at least medico legally you are on the safer side when you have actually a government dots panel referring the patient to take
But would
ATT.
they start ATT for a patient
They
with
don't, they
only
don't, they
recurrent
don't, they
implantation
don't,
failure?
they don't,
Exactly.
they don't. And they
Exactly.
will very clearly write it out to you that you should not start. But at least in that respect, you are kind of, in today's time, we
Right.
have to be very careful. Because you
Absolutely.
might not start. The other doctor might said, oh, that doctor should have started TB medicine for you. Then you would have had a successful pregnancy. So we are living in that era where everything is a
Yeah.
double-edged sword. So it's always
Exactly.
wiser to safeguard yourself and take a call accordingly.
Okay. Dr. Shrija, any inputs to this
Yeah,
question?
definitely I would discuss the option with the patient. So I would take a patient's opinion also, discuss that with them. And I would also discuss refractory thin endometrium, recurrent implantation failure. I would also discuss the option of surrogacy. So, and option of ATT for 6 months if the patient, depending, and I'll tell the pros and cons, taking the patient's consent and,
And
reach
go
a
ahead.
consensual decision.
Absolutely. Okay. Okay. So there is, in fact, a paper which has been published on this particular aspect by our very own Dr. Kaberi Banerjee madam in 2025, this very year, in the Indian Journal of Tuberculosis. And they have evaluated 45 women suffering from infertility with recurrent implantation failure, history of repeated miscarriages, curetages, hysteroscopy, laparoscopy, adhesolysis, and they have started prophylactic anti-tubercular treatment in these patients. They have found a pregnancy rate of 68%. So 31 out of 45 patients did conceive, a clinical pregnancy rate of 64%. So 29 out of 45 did have a clinical pregnancy rate. So their conclusion was that it did improve the endometrial thickness, pregnancy rate, and clinical pregnancy rate in IVF. But again, we do need larger clinical trials, larger studies to make this a guideline because anti-tuberculosis treatment goes on for almost 6 months, and it is very difficult sometimes to counsel the patient unless you have, very robust evidence that it is going to work or not in this aspect. So, ESHRE or any of the other bodies do not advise this at the moment. But again, being from India, I think we should be in the forefront of this kind of study whenever it comes to genital tuberculosis. And I'm sure all of us, being such brilliant IVF consultants ourselves, can actually take the lead. Coming to the next question. So this is spot diagnosis. Can I ask Dr. Sarika? Spot diagnosis? Yeah.
Diagram A.
All
is
three are the
showing
same. I mean, it's only one diagnosis.
Okay, it's a fluid in the endometrial cavity,
Okay.
which I can see. And the other one is in this diagram, which may some polypoid structure or a
Okay.
synecdoche, what we
Yeah.
can say.
So it is an intrauterine synecdoche. This is a saline infusion sonography which was done. And it is showing, as in the first picture, it is a very obvious adhesion band which can be seen on a 3D saline infusion. Also, there is a distorted cavity scarring which is present, and on the third as well. So intrauterine synecdoche, can you enumerate very briefly, Dr. Shrija, the causes, diagnosis, and management in one line?
Yeah, the causes include iatrogenic, infectious causes, Iatrogenic include curettage, the hysteroscopic myomectomies, hysteroscopic septal resection. Infectious include tuberculosis. So the diagnosis is by hysteroscopy or HST or sonohysterosalpingography.
Yes.
Management, I would go for a hysteroscopic adhesiolysis. I would put in a copper-T and I would put her on estrogen progesterone for the next 3 months, and I might do a relook hysteroscopy after 3 months, and I would also consider stem cells, hysteroscopic stem cells. After discussion with the patient, because it's costly and the patient has to afford it. So I discuss the option of stem cells with the patient.
So Dr. Shrija, how many patients have you tried stem cell therapy in? And what has been your experience in these particular patients? And what were those patients? And what was the indication for stem cell?
I would say mostly it is iatrogenic causes. I've tried stem cells, and I would say I wouldn't. I have not had very good success rates. Maybe out of 10, I would have had three pregnant patients who have had menstruation after stem cell therapy, and I've not had any clinical pregnancy rates after that. But patients have had menstruation and normal cycles. 3 out of 10, I would say. It's not
3
very.
out of 10.
So I
Okay.
have to discuss the options with the patient and then take a call on that.
So how do you counsel the patients about stem cells? What do you tell them that what
It
is
is
going to
not
be
a
the
proven
success of?
therapy. It is not a proven therapy.
Okay.
It's an empirical therapy. Maybe it would help. It has helped some patients, but less than 50%, I would say.
Okay. Dr. Ashwati, any insight on stem cell therapy?
No, I think it is still very nascent, quite invasive to, unless for me, if it is too evidence-based, then only I would incorporate in my practice, and especially when it is an invasive modality.
Okay. Dr. Vishwaja, stem cells, have you used it? Any experience with stem cells? And how would you counsel the patient? Is Dr. Vishwaja here? Dr. Ashwini?
I have not tried it because there are no enough evidences. Definitely, it is an invasive procedure, and considering risk, and also once there is a proven evidence, then I will try.
Okay. Dr. Sujoy?
No, I haven't yet tried this stem cell therapy, as all the panelists said, because I'm very much skeptical, because it's not yet been proven therapy, and it's quite
Right.
invasive.
Okay. So with respect to PRP, Dr. Archana Madam has taken a very elaborate and wonderful talk. So we will not go into the details of PRP. But when it comes to stem cells, yes, it is it does hold a potential promise for the future in cases of refractory thin endometrium, severe Asherman's, repeated implantation failures despite optimal HRT. It helps in angiogenesis, glandular regeneration, fibrosis reduction. In this very year, 2025, there has been a paper which has been published in which the author, Santa Maria, who in fact was also involved in the pilot study of stem cells in 2016, this is a follow-up paper, a phase 1 and 2 trial, which they have shown that they were getting good results after bone marrow derived stem cell injection. And implantation rates per embryo transfer were 31%. Live birth rates almost 30%. So 6 out of 20 patients did conceive. Miscarriage rate also was around 30%, and all newborns displayed normal development. So this was a long-term study for complications as well. However, stem cells do have their own pitfalls. It is quite invasive to harvest from the bone marrow, high cost, variable protocols, age-related decline in autologous cells, long-term safety data also we don't know with respect to immunogenicity and tumorigenesis. And therefore, we require larger studies so that it is not still an experimental therapy and can become a standard of IVF care. Other newer avenues are exosomes. So when I was researching exosomes, in all the papers of exosomes, they were talking about stem cells as traditional stem cell therapy. This is how fast the medical field is advancing, where stem cells has already become a traditional therapy or a conventional therapy, and they have moved now onto exosomes. So exosomes is a cell-free therapeutic alternative capable of delivering similar regenerative signals with lower immunogenicity and tumorigenic risk. But all said and done, the newer avenues of stem cells and exosomes holds considerable promise, However, lack of large-scale randomized controlled trials limits the widespread clinical adoption of these therapies. So I think we have come to the conclusion of this panel. Before we all disperse, I would like each panelist to give just a one-line take-home message, a very crisp one-line take-home message for our audience today. Has Dr. Hasina come? Starting with Dr. Hasina. Dr. Jeevan Chaudhary, sir?
Both are not there, I think.
Okay. Dr. Sarika?
I would just like to say that after seeing or after needing the experience of the other people, I just need to be more confident to go for the transfer, even if the endometrial thickness is less than 7 mm. That's what I can say. If all the things is all the other parameters is in a normal way.
That is the whole point of a panel discussion, where we learn from others' experience also, and it kind of gives us the confidence to make our own new mistakes and not repeat things which others are doing.
Yes,
okay.
definitely.
Dr. Shrija?
Yeah, I've learned a lot from this panel discussion and the lectures. So, refractory endometrium is not something we cannot treat. I feel most of the cases, I think around 80 to 90%, it is treatable. And before telling the patient about other options like surrogacy, we have to tell them all the options, explain to them all the options possible, and treat.
Dr. Ashwati?
So I think we've covered a lot of things in this panel. One thing that I would want to add, and I feel it's a wonder drug in thin endometrium, is tamoxifen citrate, which is an estrogen agonist, which can be a replacement for letrozole. Do try it. I use it a lot in my practice, where, even with high dose estrogen, I'm finding the endometrium refractory, where the pattern is fine, but it's not working. Try tamoxifen.
Okay. Dr. Vishwaja? Okay. Dr. Purnima, ma'am, is she here? Dr. Ashwini? Sorry? Dr. Ashwini?
So I would say कि we discuss about about thin refractory endometrium. So we should focus on quality of endometrium, not the thickness. So like adjuvants, as we discussed, so we should start using the stem cell. So that we, as you said, कि this is old one. So we have to start somewhere with the advances also. So definitely with the thin endometrium and Escherman's, we should try stem cell therapy.
Okay. And Dr. Sujoy?
Yeah, first of all, thank you for the panel discussion, because it really enriched my knowledge and I came to know about different roles of different the adjuvants. But one thing I'd like to mention, there's a paper published in Fertility Sterility probably 2 years ago, which mentioned that for recurrent implantation failure, in 80% cases, the embryos are responsible and endometrium accounts for only 20% cases.
Correct.
Therefore, thin endometrium may not be as important as we think, because sometimes we may get pregnancy and live birth even with thin endometrium. So it's maybe the quality of endometrium that matters more than the actual thickness.
Okay. Okay, so thank you so much, everyone, for your expert insights. And this was really an enriching panel, even for me. Thank you, Dr. Archana ma'am, Dr. Asha madam, Dr. Rupali, Dr. Anjum, for the opportunity. And congratulations to the entire organizing team for putting up such a wonderful webinar. I think everyone who has not joined in today has really missed out on something very important and very enriching. Thank you so much.
Thank you,
Thank you.
Mrinalmai.
Thank you
Thank you
so
so
much.
much
Thank you.
for really conducting a wonderful panel.
Thank
Actually,
you,
it was quite enriching. And I think, as Sujoy also said, that, endometrium quality is important. So all of us are practicing ART specialists, and maybe just even gynec who are practicing infertility is very, very important. That yes, thickness is important, but very important, like if there is a recurrent implantation failure nowadays, there are tools on the machine, you can measure the volume also. So endometrial volume assessment can be done to improve the implantation. But it was nice, really conducted panel. I think the inputs from all your panelists were so good. And I think whenever you prepare, I mean, Mrinal, you must have seen that you learn while preparing also, because
Absolutely.
you have to
Yes.
handle 8 or 10 panelists from the different parts of the country, their
Exactly.
inputs. So because to take out the inputs from the panelists, you really have to put in a lot of efforts. So which you did, and you really
Thank
did
you.
justice to the moderation
Thank
of this very difficult panel, I should say.
Thank you
Because
so
it is
much.
a common topic, common problem, but
Yes.
uncommon solutions.
Absolutely.
That is the thing. So thank you very much, and
Thank
I
you
would
so
like
much.
to thank from bottom of my heart to all the panelists who have really, stayed for the panel and contributed to this. Thanks to all our guest of honor, chief guest, and Dr. Asha Bakshi, and my dear friends, Dr. Rupali and Dr. Anju for
Thank you.
contributing, and thanks to Format Sudeep ji for providing platforms seamlessly. And one very important person is Aditi, who has really done
Yes.
Temosi so well. So good to know Aditi, and really done a wonderful job, all of you. So have a nice weekend and nice new happy new year to all of you. I look forward to see you soon in future in some of the conferences or CMEs, whether it is AICOG or maybe RCOG conferences. So look forward to meet you all in person soon.
Thank you, Archana ma'am. Thank
Thank
you,
you. Thank you.
Ma'am, for moderating a very nice session. All the panelists who joined us from different parts of the country. The MOC, Dr. Aditi, you did a wonderful job. I miss Rupali today as she's down, but she has been supporting throughout. So, best wishes to Archana ma'am, who is contesting for the election year 2026 for the President Foxy. And we look forward to having you again for future meetings. Thank you so much.
Thank
And
you so
Sudeep
much,
sir,
Dr.
Thank
Anju.
you.
thanks a
Thank
lot.
you.
Sudeep
Thank
sir,
you.
thank
Thank
you.
you.
Thank you so
Thank you
much.
so much, everyone.
Thank you.
Have a good night. Thank you. Bye.
Bye.